So welcome, everyone. From Georgia, let's see here, Missouri, St. Louis, Virginia, some Oregon folks, Ohio, Florida, Missouri, Madison, North Carolina. So what's interesting about seeing all of your places you've been, there's, I think I've mentioned this yesterday, but I literally have trained maternal health case managers and home visitors in every single state in the country many times over, with the exception of Delaware. So at some point, I'm going to have a conversation with Mr. Biden and say, hey, we need to do some training with maternal health people in Delaware. Louisiana, Colorado, which is where I was born in Duluth and I grew up in Colorado. So I know exactly where Clayton is. Lawrence, Massachusetts. Hi from Louisiana and Kentucky and Buffalo, New York. And more folks from Massachusetts and more folks from New York City specifically. Hey, Harlem. Let's see, who else is joining us? Friends from Georgia. From Massachusetts. New Jersey. South Carolina. Santa Cruz, California, awfully close to where I am. I'm in Berkeley, California. Hi, Shirley. Hi, Sarah.
Right, it looks like our participants for the most part are here. So I'm going to go ahead and get us started with a little bit of an overview of the Maternal Health Learning and Innovation Center. For those of you that were able to join us yesterday, you may have already heard this, so I will be fairly quick. But the Maternal Health Learning and Innovation Center is the organization that is hosting this training. So we wanted to let you know a little bit about who we are. We are funded by HRSA and the U.S. Department of Health and Human Services. So we thank them for their generous support. The mission of the Maternal Health Learning and Innovation Center is to foster collaboration and learning among diverse stakeholders to accelerate evidence-informed interventions, advancing equitable maternal health outcomes through engagement, innovation, and policy. The center's central goal is to provide a continuum of learning opportunities that enhance the capacity of all maternal health practitioners across the country. We were established in November 2019, and the MHLIC aims to advance federal and state level efforts to eliminate preventable maternal deaths and reduce severe maternal morbidity, using equity as a cornerstone of all services. The MHLIC provides resources and capacity building assistance in 3 specific areas: maternal health policy, community and provider engagement, and maternal health innovation. We actively work to center anti-racist principles and continuous intercultural development. Our team includes maternal health policy, innovation, engagement, and implementation experts from a variety of different organizations, including the American College of Obstetrics and Gynecologists, the Association of Maternal and Child Health Programs, Georgia Health Policy Center, Race for Equity, Reaching Our Sisters Everywhere, and UNC, including the Gilling School of Global Public Health, the Jordan Institute for Families, and the UNC School of Social Work and School of Medicine. You can visit our website at maternalhealthlearning.org to learn more and explore our National Resource Center and sign up for our newsletter to stay informed of upcoming events. And you can also connect with us on various social media accounts to keep up with the work that we're doing. So from here, I will turn it over to Rebecca Levinson, who will be leading the training today. Rebecca has decades of experience helping healthcare systems respond to intimate partner violence. She is a former Planned Parenthood clinic director and domestic violence policy analyst for the national nonprofit Futures Without Violence. Rebecca is a nationally recognized researcher, educator, advocate, and speaker. She is the architect of the Futures Evidence-Based Intervention CUES, which you'll learn more about today, which applies the universal education and altruism to improve providers' ability to help clients experiencing IPV. Ms. Levinson is an author of numerous additional IPV training resources and publications. So thank you for joining us again today, Rebecca, and we look forward to learning from you.
Thank you so much, Kelsey, and welcome back for those of you who joined us yesterday, and for those of you who are new today, welcome. I did want to just call out a couple things. My colleague, Virginia Duplessis at Futures, who is a lay doula on top of everything else beautiful she does, couldn't join us today. So I wanted to acknowledge her as an author of this curriculum. And then I also wanted to acknowledge Dr. Linda Gilkerson from the Erickson Institute, who allowed us to use her beautiful model called the Fan, which was introduced yesterday. And we'll talk more about that today. And then also special thanks to our friends at the Washington State Coalition on Domestic Violence for sharing their wisdom on safer planning and just the beauty of their work partnering with home visitation and other maternal health providers in their state. So there's a lot of wisdom that has gone into this. There's a lot of love that's gone into this curriculum, and you are among the very first in the nation to see it. So I'm very excited to have you here today with me. One of the things I want to start with is I always recognize that there are survivors among us. If you become triggered, this is being recorded, you can leave. You can go out, wash your hands, catch your breath, come back to it at another time. And if you're someone who's experiencing difficulty in your relationship, you're feeling unsafe, you're feeling unsettled, or this brings up things for you, I really want to encourage you, call the National Domestic Violence Hotline, which is listed here, for supports. The hardest thing for me is that we're not in person together, so I can't read the room, so to speak. So again, just really take care of yourselves as we move forward today. Okay, so my friends who were with us yesterday, were you able to do something around self-care between yesterday and today? So buddy system, grounding, finding alone time, maybe that was in your car or around the corner from your driveway. If you wouldn't mind sharing in the chat, I'd love to hear. Was anybody able to do anything between yesterday and today? You can share in the chat. I went for a nice drive to relax. Thank you. Spent 10 minutes in a massage chair. Yeah, I want to know if that's in your house. I pet my dog for positive affirmation. I went for a bike ride. I exercised. I got a good night's sleep. Yes, downtime. It's in my agency. Spent time for prayer. Did my nails. Snuggled my babies. Cooked a delicious dinner. Had a hot shower. I took a nap, walking. So I love that folks, took action. And for those of you who weren't able to, no judgment, but just this is something that has to be an intention. And I'm so happy that some of you were able to engage around the intention. So I want to give you just a little roadmap of what we're going to be covering today, right? So module 1, we're going to be looking at ACEs and a new frame called HOPE that I think you're going to be as excited about as I am. Second module, we're going to be looking at definitions, dynamics, prevalence, and impact of IPV. Module 3, we're going to be reframing intimate partner violence with a health equity lens to understand maternal mortality, mandatory reporting, and ways forward from systems that have engaged in harm. We're going to take a break at that point, and then we're going to move on to rethinking our responses to IPV in the context of health equity and universal education. So that's that cues module Kelsey mentioned. We're going to have another little break, and then we're going to close out with this concept of safer planning and working with people who cause harm. And again, I'm looking forward to it. So as I mentioned, we're going to start with ACEs, which stands for Adverse Childhood Experiences. And we're going to be looking at this new concept called hope. But just like yesterday, I want to just take a deep breath with you all. If you're comfortable, you can close your eyes and take a deep breath in. Just take a second to get grounded before we start learning together. Thank you. All right, so I'm going to share a very brief video on what ACEs are for those of you who haven't learned about it yet, and then we're going to debrief this video.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems and empower them to make changes for themselves and their children.
And I'm going to stop there. And
ACE.
what stood out for you in the video you just saw? And you can share with me in the chat, or you can come off mute if you want. But what stood out for you in what you just saw?
That ACEs is not destiny.
ACEs is not destiny. Yeah, I think that's a really important piece. But I think even the music feels kind of dark to me. I don't know about the rest of you.
Good point. Yep.
It felt a little dark to me. And, that's really where the work started. I had the opportunity to see Vincent Felitti speak in 1998, so the year the study came out. And I remember being in a conference room, sitting at a table with a tablecloth on it. And I'm groping this tablecloth as I'm listening to him talk about all of that data, because my ACE score is 8. And I was thinking, now, wait a minute, wait, what? And can anybody tell that my face is all red? And, it was like a little bit of we actually did our ACE scores. It was a big thing for me in that moment. And I remember thinking, well, I'm not, drug addict or any of these other things. And wait a minute, how does all this fit together? And I just have been sitting with the darkness for a long time. And I feel like a lot of us who got trained early on kind of was looking at ACEs through that lens of all bad things, even though we know that it's population-based data versus individual data. And I think that there's a very interesting way to kind of hold that space. So in addition to, and we're going to talk about that in a minute, but in addition to, looking at the adverse childhood experiences study, of course, we've been doing research and thinking about this for a very long time. And of course, we know that social determinants of health, other kinds of things can lend themselves to ACEs, right? So histories of discrimination, historical trauma, lack of jobs, substandard schools, poor water and air quality, substandard wages, poverty. These are all things that can lend themselves to these manifestations that are ACEs. So when we think about what do we do to help do prevention, we need to address these social ills, these social issues at a core level as we move forward in our work. And I want to give you an example of this is a concrete example. I want you to look at this picture, and I want you to notice what you see. What are you seeing in this apartment? So why don't you tell me in the chat, what are you seeing?
Hello, this is Irene from Harlem Greater Healthy Start. I'm seeing a lot of chaos.
Fair, right? So let's do this for a second. We see, things piled in the sink, right? We see cracks on the wall. We see bugs on the wall. We see all kinds of things in this picture. And I think that what's so powerful about this is there's two ways to look at the same picture. And that's kind of the concept of hope and where we're shifting from with the sort of darkness of the original ACEs work to where we want to go. And, but the flip side of looking at this picture is this. What do we see in this picture? Well, there's another way to look at it. We see that there's food for this family. We see that this family they're housed. They're not on the street. They're not in a car. We see that mom's reading a book. We also see that actually the baby looks like it's content and sleeping. The other child that's watching TV looks content. The baby in the toddler in their playpen looks content. We also notice that there's spirituality in that home. We see a big picture of Jesus on the wall. And we know spirituality is another thing that is a bolstering effect for families. We see that there's cleaning supplies on the floor, and there's two ways to look at that. On the one hand, how exciting that mom is getting ready to do some cleaning, right? Versus, oh my gosh, we have to worry about the risk because there's cleaning supplies on the floor. So the idea is that, do we, as we look at families, are we looking through a strength-based perspective, or are we looking through the things that are hard in that family perspective? And I think that what we've been learning about this new framework is so important, because if we can start by looking through the lens of the positive, asking ourselves, what is strong about this family? What is good that's happening in this family, rather than what are the adversities that they're struggling with? It's a different way to hold whole populations. So the question I'm going to ask you to ask yourself is, what was easier for you to see, the protective factors or the risk factors? Because, and you're not alone if the first thing you saw were the risk factors, because that's kind of in some ways how we're trained to look at things. But this is a very interesting framework, and I'm going to share with you some data and some other thinking about this. One of the things that I heard from Kelsey is that the Maternal Learning Center is all about looking at equity. And one of the things that we want to do as we're thinking about equity is look at the issue of implicit bias, right? And implicit bias is something we all have. So for example, it's called type 1 thinking, right? So if I'm crossing the street and a car's coming at me, I don't have to think, what should I do next? I know what to do next. I'm going to jump out of the way. So we have a lot of things that we do in kind of a very quick fashion in our brains. All of us do. And so sometimes it's about measuring those deficits, about seeing the world that way fast and quickly and measuring it that way. But if we want to slow ourselves down and move out of implicit bias to a place where we can be really fully seeing whole people, whole families, seeing the assets of the family, then we have to be intentional about it, because it's pretty easy, because our brains are naturally wired to kind of quickly put things into categories, and we have to slow ourselves down to make that change. So looking at that picture and framing it through the positive is sort of an action that I'm hoping we all do as part of the work around approaching our families through this strength-based process. So as I mentioned, implicit biases are embedded in type 1 thinking and that kind of quick thinking that we all do. And what helps us get rid of those negative biases is when we slow down and when we really notice. So yesterday we learned some tools to become really present in ourselves before we start working with families, to notice where are we, to get our heads clear, to be intentional. And I would argue that being intentional about seeing the positives in families is another element to add to what you learned yesterday. So why hope? What is hope about? And it's this whole science and theory of positive experiences that help children grow into resilient, healthier adults. So when we frame it in the positive, it matters. The positive exists. It's real and it's worth growing. And we know from research, when we approach folks with empathy, with positivity, with seeing the best in them, right? What do we get? We get more connection, more relationships. So all of you who do this work in maternal care that build those relationships with birthing people and mothers, I know you know this trust piece is really important. Are you concretely including it in the ways that you begin the work with the families you work with the parents you work with? We know that positive experiences promote children's health and well-being. It allows them to grow strong relationships, cultivate positive self-image and self-worth, gives them a sense of belonging, and it promotes resilience. Many systems focus on the negative, and a lot of screening tools, just like that ACE tool, right? So how many of these bad things happened to you when you were 18 years or younger, are focused on measuring the bad things rather than tools that are focused on measuring the good things. And I want you to stop for a second and think about it. How many tools do you have that measure hard, bad things? I bet there's a fair number of them. And it's, of course, it's important to understand what adversities are happening, but But let's think about this for a second. How many tools do you have that are measuring the positive? Maybe you have a few, but I think that this is a really important thing as we're thinking about how to undo implicit bias in our work, right? So screening tools, many of which codify implicit bias, create a presumption of deficit. It's pretty hard if you've got an ACE score of 8 to not think a lot of things about me or think a lot of things about me as a potential parent, right? We can see how those numbers might be associated with certain behaviors or certain risk factors in our own minds. So the idea of hope is it's shifting the narrative. And when we define people by their strengths as well as their challenges, we can create this presumption of strength and really change the way we hold folks as we're working toward seeing people in their wholeness and seeing their best selves. I want to talk about a study that was done. So just like the ACEs study in the state of Wisconsin, they decided to add on to the ACE questions that were being asked on this survey. The BRFIS survey, behavior risk family survey, is done in all 50 states. It's a telephone interview that's done. And in the state of Wisconsin, they decided to add on additional questions about positive experiences during childhood, not just and only ACEs. And here were the questions that they asked. As a child, how often did you feel like you could talk about your family and your feelings? Feel that your family stood by you during difficult times? Enjoy participating in community traditions? And that's looking at spirituality and other elements of what community means in lots of different contexts. Did you have a feeling of belonging in high school? Did you feel supported by your friends? Did you have at least 2 non-parent adults who took genuine interest in you? And for my friends who are doing work with families and home visitation and maybe extending out your relationship till children are 2, 3, 4, 5, you are one of those people that's taking genuine interest in that child's life. Did you feel safe and protected by an adult in your home? Now, I'm not suggesting these are questions you should be integrating into what you're doing, but I do want to talk about the results of them because it is this framework it's a broader framework that I'm wanting you to understand today. So what did we find out? That the positive outweighs the negative. So folks that had 6 to 7 of those positive experiences, in terms of mental health, only 12% of them were struggling, versus folks that only had 0 to 2 of those positive things that happened in their childhood. So we can impact the positive things that happen in people's lives, right? That's part of your role as maternal healthcare providers. And so thinking about how we can, build this into the work that we're doing with families means that we can change the trajectory of mental health. And I want to get even more specific around ACEs. So you see here, we were looking at that same population in Wisconsin that had the positive experiences versus the ACEs experience. And I want you to notice this, right? So again, if you had 4 or more ACEs and you had 6 to 7 positive things happen to you growing up, you see that the huge difference between the depression levels of the people with very little supports that were positive in childhood versus the people who had a lot of them, right? Huge difference. So 60% of folks with 4 or more ACEs are struggling with depression if they had no supports, and only 20% are struggling with depression if they do have the supports. So I want you to let that sink in for a second, right? So we know positive childhood experiences protect adult mental health, even with ACEs. And I want you to think for a second about, what does that mean to you? Does that change anything about what you're doing in your practice? Does that make you think about, I wonder if we could insert your idea there? So to sum it up, right, we know that positive childhood experiences can help block toxic stress. It can build resilience. It can promote healing if you have had difficulties in childhood. And it can improve your health outcomes in adolescence and in adulthood. So how do we do this? How do we integrate this positive framework in what we're doing? And I think it really is about relationships and thinking about how we can expand our conversations about who else is in your life that's there to support you with this baby. Oh, so you said your mom's coming over and she's going to spend 2 weeks with you. That's awesome. When she goes, who else can be there to support you? It's thinking about ways in which we can build on what we know helps, and also reinforce to parents that we know these additional outside relationships really help children thrive. So it's reasons to be connected to really good childcare, to early preschool, or good childcare for kids, because we know that those teachers in those settings also help. So are we doing as much as we can around resources and connection? We know that safe, equitable, stable environments for living, playing at home and in school makes a big difference. So as part of our work, are we talking about, where folks can have access to food pantries if they need it, and housing and early childhood care? Are you using 211 as a resource? Because that's a place where there's a repository for more supports there. Are we thinking about how to do wraparound services? Could maternity care be, co-located with other kinds of systems of care, right, for families in your community? Could there be, and maybe this is happening for some of you, but I just think that we know so much at this point about what can make a difference in the lives of families and children, that we're just really excited about it. And then, anytime there's an opportunity with older children to give them a sense of giving back in their community, we know that builds resiliency too. And then, of course, social emotional learning. And I know some of you integrate this into your programming, but it's a hugely valuable thing. So if you grew up in a home where you didn't see kindness modeled, or how to resolve a difficulty, an argument, etc., really doubling down on offering tools and supports for how you can calm yourself down, or strategies for families that maybe never had the opportunity to have those experiences themselves. How can you integrate that into the work that we're doing? Because we are talking about prevention, and we're talking about earlier intervention in the case of intimate partner violence and kids being exposed. So hope and healthy outcomes are strength-based, they're child-centered, they're family-led. So this is about really, again, centering equity and centering our goals around slowing down our thinking so we can avoid implicit bias, and seeing families through a lens of all their strengths, all their power, all the good things, as opposed to quantifying all the negative things as a first step. Moments of hope can happen at any time. It can happen in the way that you do your next patient encounter. It can happen during intakes and assessments. So let's think about this for a minute. I asked you, so what kinds of tools are you using to measure the hard things? Well, could we start with tools that measure the good things first, and start our conversations around what's working? What are you excited about? And again, some of you are already doing this. Maybe you're doing it intuitively. Maybe you've learned about this framework. But for those of you who haven't, I want you to think about the difference for you walking into a healthcare setting and having someone measure the things that are going well in your life versus the things that might be hard in your life. I think understanding families' strengths and hopes and dreams is a way to connect with them. I think it's the basis for collaborative problem solving, which is what we want to do with patients and clients. And I think for you all as healthcare providers, or as those working with in maternity care and working with birthing people, I think when we set up this framework, and they're doing research on this right now, it can help reduce burnout for you. So I'm going to stop there and just see if anybody has anything they want to share about what they think about the HOPE framework, how we sort of shifted from the dark side of ACEs to this new way of holding things, and if anybody would like to share their thoughts or feelings about what we just went over. Good buffers can offset many ACEs. Appreciate the inquiries of positive framework. Not sure how well the tools translate to clinical work. Fair. And I think that that's the challenge I'm offering here is, can we rethink all the measurement around hard things and put in place some pieces that are measuring those strengths as part of clinical care? Because in fact, it does good things both for you and the client. So I appreciate that. Anything else here? Happy to see the science behind what has been done in the field for some strength-based led programs. Thank you for that. Understanding family dreams may be hard for some. Yeah, that's fair. That's fair. And I don't want to be Pollyanna-ish about this, but I do, there's a whole, this is a framework, but there's a whole set of tools, thinking. This is a national initiative. You can go to the Positive Experiences website, and they have so many examples of the kinds of ways in which you can integrate this into your program. Whether you're a clinician, this is actually born out of pediatrics, just so you know. So it's clinical settings where this was born. And there's just so many other tools and resources there. And it's on your list that I promised to give you all in terms of resources. So you don't have to panic and look it up. We'll be sharing that with you when we share out the resources again today. Okay, so I want to shift gears here. And moving beyond the power of hope, I want to talk about intimate partner violence, IPV, the definitions, the dynamics, the prevalence, and the impact. Why is it important for home visitors and perinatal case managers to know about IPV? Go ahead and share in the chat. Why is it important for you to know about IPV? What comes up for you when you think about that question? It's important because it increases during pregnancy, safety for mom and kids, safety for the worker, recognizing the signs of the IPV, explains noncompliance, safety. It affects everything for that person, how they live, how they operate. Exactly. And that's one thing I think is worth really noting in terms of the goals of your program, whether it's having the best birth outcome possible, to maybe for some of you who are working with families around parenting skills or family safety or social supports, I can show you literature that shows how intimate partner violence gets in the way of every goal that you have, including maternal outcomes, and including low birth weight babies, including increasing miscarriages, including all of those other kinds of things. So it's important. And also, I really heard the piece about it's important for you to know how to keep yourself safe. And we certainly have a sample protocol on how to do that in your setting. So that'll be an additional tool that's sent out to you all today. I think that it's important to kind of understand intimate partner violence, a big picture. I think often we think about injury first and foremost when we think about intimate partner violence. But in fact, it's a pattern of control that's about power and control. And that power and control can affect health and well-being, whether it's power and control around finances or power and control around the ways in which you treat someone, name calling, all of those kinds of things. So we see it show up in all different kinds of ways. It's often a cycle that gets worse over time. Abusers can use jealousy, social status, mental health, money, other tactics. Again, not just physical violence. And, and certainly sexual violence is part of it. So if you have clients who maybe don't come in for that postpartum visit, one thing I want you to consider is whether or not maybe she ended up or they ended up having to have sex they didn't want to, and those sutures that you carefully used were split and they're embarrassed, or they don't want to come in and have that revealed to the provider. So if you've got someone who's not coming in postpartum, these are the kinds of wonderings I want you to have in the back of your head. In the research that we did, and I put an asterisk by emotional, we've done work looking at folks who experienced all kinds of harms, including physical violence. But when we ask people of all the things that happened in your relationship that were hard, what kind of stands out for you? And so often people say the same thing, and it's the words. Being told that you're worthless, being told that nobody else would want you, that you're a bad mother, that nobody would want to hire you, all of those kinds of things. So as you're thinking about the ways in which you're having conversations with your clients, I really want to encourage you to move beyond thinking of the physical violent part and really think about this power and control part. And I'm going to be giving you tools and resources to expand those conversations moving forward. I mentioned economic before. So if you've got somebody who's late to appointments or missing appointments, are they able to get access to money? Can they use the car? Are they allowed to? Is that part of how power and control is showing up? We certainly saw with COVID an increase in trafficking as part of what's happening. So forcing a partner to have sex with other people in order to make financial gains for the partner and the other partner in the relationship. And then of course, there's this, the issue of reproductive coercion. So when a partner's using power and control to get you pregnant when you don't want to be, or force outcomes connected to pregnancy. I do want to mention that power and control for undocumented persons is very real. Those tactics around fear of deportation or using children are a big part of it. And I think it's important for any of you who are working with undocumented folks to understand what their rights are and help them understand what their rights are. Those are conversations that would need to happen because I think for many undocumented folks, they'd be very afraid to disclose any intimate partner violence without more information about what their rights are. There are supports for them, that they can go to shelter, that they can have access to all the same kinds of things that undocumented folks can have access to. And I'm not sure every provider knows that. So I wanted to make sure that you all had access to this. And Kelsey, this is something you can drop in the chat too. This goes back to the National Domestic Violence Hotline, but the undocumented and experiencing intimate partner violence, what are my rights? Reaching out for support is from that website. So this is a very short video, but I think it sums up some other ways power and control is showing up in relationships. So I'll share this with you too.
Because I love you. I want to be your only guy.
Because I love you, skip class with me. Let's stay in bed today.
Because I love you, I just want to be with you so freaking much.
Because I love you.
I waited for you after Chem Lab.
You were walking with Mark?
Because I love you.
You shouldn't be hanging out with that dude.
You should know how dumb that makes me look.
I don't care if she's your lab partner.
Why do you have texts from him?
Because I love you. This number,
Delete.
Because I love you. This Jason number?
delete.
And Ben,
Delete.
because I love you, I should smash your phone.
I'll let you give me your password instead.
Because I love you.
I will check your texts every day.
You got lucky. Because I love you.
Because I love you.
You think it's okay.
Because I love you. You understand.
Because I love you, you stop talking to your classmates. And you feel completely alone.
Because I love you. That's not love.
Because I love.
So I'm going to ask, and you again can come off mute or you can share in the chat. We just went through a lot of pieces connected to intimate partner violence, the ways power and control show up, including that video. Did anything stand out to any of you or resonate, or it's kind of an aha moment? I think that power and control around social media and phones is really important. So I'm going to look at the chat here.
The way it was gradual, it just started kind of benign and built up. So it sounds okay at first, and then you get in deeper.
Perfect. That is, and that's the truth for so many people, right? It starts with these little things and it moves on from there. Tone was sending a real message. I noticed how I love you changed in tone. Absolutely. Yeah. it looks like all of us, right? What stands out in the video as a more obvious way, I've got to go back. Oh, you guys are so fast. Thank you. But it's really a much longer process. It happens so gradually, you don't even realize it. And that's actually the power of all of you, is that when we talk about what people deserve in relationships and what they don't deserve in relationships, I think that that can shake things loose. And I think the way that we do that really matters. So I appreciate everybody here. I'm looking now, the other messages. Actually made me think about how this could start at home with parents who hit their kids and abuse them because they love them. So seeing it bigger connected, I can see it being used as a progressive and confusing thing for some people, right? And so because I love you, it's a pretty powerful way to frame control, isn't it? Because I love you, I have to do this. And so really thinking about how we're talking to our clients and patients about this, I think really matters. So thank you for thinking with me on that. So this is from my friends in Washington, the Washington State Coalition Against Domestic Violence. I love this sort of thinking, so I wanted to share it with you. The best way to support children is to support parents who aren't engaging in harm. We know this. We know that abusers only use the amount of force necessary to control someone. So I was working in Montana, and I had a survivor disclose that her partner would leave a bullet on the back of the toilet seat. Never threatened to kill her, but all you needed to do was look at that bullet, and the message was very clear, right? So really thinking about that, people only need to use the amount of force necessary to get behavior that they want out of that person, or get them to do what they want them to do, or to control them. Past abuse does matter. Survivors have been surviving forever. We want them to be the experts in their own lives. I think that's really important. We're going to be talking about that a lot today. We need to let survivors drive. Forced sex might be the only abuse that they're experiencing. So talking about all the ways in which power and control can show up, including maybe not getting to make decisions about when you have sex, or how you have sex, or if you have sex, I'm hoping is going to be part of the conversations you have with your patients and clients. I also think this last little piece here is really crucial. Not telling, not sharing your story is not the same as lying. And so I really want us to think about that, because we're going to be looking at all of the reasons why people can't or don't share their stories with us. And I think it is absolutely a health equity issue. I think it's a systemic issue that we need to be looking at relative to the histories of the way healthcare has shown up in different people's lives. So let's talk about how prevalent this is, right? So we know that 1 in 4 women will experience this in their lifetime. We know the highest risk ages are 18 to 24, and there's a high percentage of mothers in that cohort. But I also want to turn your attention to the yellow box, right? So we know that 61% of bisexual women and 37% of bisexual men, 44% of lesbian women, 26% of gay men have experienced rape, physical violence, and stalking by an intimate partner in their lifetime. And if we look at transgender individuals, 34% have experienced physical abuse, and 64% report experiencing sexual abuse. So we want to be having these conversations very broadly, and be thinking about, again, making sure that we're inclusive of birthing folks as well as mothers in the process. If you live in a rural area, and I saw some of you would put in the chat that you are from rural parts of our country, we know that the incidence of IPV in those settings might be as high as 50%. There's a reason why sometimes abusive partners want to be in rural areas, or control the ability for their partner to be able to access everything from cell phone service to transportation, all of those things. So again, you might be the only person that client can talk to about those issues. What do we know about COVID? intimate partner violence increased, right? There was an increase of 9% with chats to the National Domestic Violence Hotline and texts to the Domestic Violence Hotline. And here's an example of something that showed up in COVID. A caller was experiencing an escalation of abuse. They had tested positive for COVID-19, and the abuser was using isolation to keep them from contacting family. The abuser threatened the survivor with deportation. The survivor is currently in the process of becoming a US citizen. So again, going back to that earlier slide I showed you, I really want to encourage you all to know that there are resources specific to these kinds of cases. And you can get a hold of all that information on the National Domestic Violence website, hotline website. Okay, so question here. Why might a person stay in an abusive relationship? Why do people stay? And you can share it with me in the chat. Here, love, finances. They think they have no other choice. Fear of being alone, economic, it was normalized as a child. Financial and immigration, no other options. Fear of being alone. Medical insurance, absolutely. All of the above. They feel they deserve it. They don't have support. The kids, they want the other parent in the child's life. They're trapped. They're pregnant and they feel trapped. Those are all reasons that people stay in relationships. So it's a really great list. Thank you for that. I think one of the other things as helpers, if there's one thing you don't walk away with today, it's this slide. Because as helpers, I think sometimes we want to fix things, don't we? And yesterday we talked about how we like to put on our cape when someone's showing up with a problem, we're going to fix that problem versus letting the patient or the client lead and following what they say is going to be helpful for them, not deciding for them. But I think sometimes we equate success with leaving, right? And that can never be the way that you measure success, because we know that leaving comes with the highest likelihood of homicide or acute victimization. So staying might be the safest choice. And that's a really important thing for you to know and tuck in your pocket or put in your boots or put on your computer screen or on your dashboard or wherever you need to put it. Because I think often people feel a sense of, oh, well, I wasn't able to really help this person because they're still with that partner. And I really want you to reframe success. Success is reducing isolation. It's not telling somebody what to do. And it's not deciding for people that leaving is the best option for them, because in fact, it might be the most dangerous option. So it's important for you all with power in that relationship with your clients to be thinking about this piece. And I think when you rethink it for yourself, it also can help you have a sense of success, right? So if reducing isolation is success in the goal and you have a conversation and you offer resources, that's a win. How does domestic violence impact women's perinatal health and their birth outcomes? And there's a lot of expertise on this call, so I'm just going to have you put it in the chat. How does it show up? What has your experience been? How have you noticed it? Low birth weight, increased risk of PPD, maternal death. Men get abused too. Let's not forget. Absolutely, absolutely. Preterm births, and I should have put women and birthing people here, so forgive me for that. Preterm births, abruptions, absolutely. Someone gets hit in the stomach. Substance use during pregnancy, not getting PNC or accepting services with home visitation programs, absolutely. Rapid repeat pregnancies. Anxiety, depression. You just did it, Dorothy. Miscarriages. Thank you. Toxic stress. And certainly we know that men experience intimate partner violence as well. We're here just today, though, very focused on maternal health, but we are going to be talking more about ACEs and sort of ways in which we can be thinking about men as we move forward in today's talk. So this is another tool from my friends at Qualitative, so Washington State Coalition Against Violence. And there's a couple juicy things in here that I want you to remember. You can't fix it. It's not yours to fix, right? Leaving doesn't mean the abuse stops. A person's goals can change from hour to hour. Staying connected is critical. Success is the seeds you plant, and we're going to be talking about why universal education is so important later today. You don't know when those seeds are going to sprout. Don't underestimate the power of listening and believing, because our research tells us that that is a key piece for all survivors. Abuse is not about losing your temper. Abuse is intentional. Supporting the mom or the birthing person is supporting kids, or if supporting the non-abusive person that's in the family is supporting kids. We all have bad and good days, that's for sure. But feeling helpless does not mean you're not helping. And I think sometimes when we're doing this work, it's really easy to feel helpless. And I just want you to think about that. You might even want to write it down on a sticky. Feeling helpless does not mean you're not helping, right? Remember what our goal is. What is success defined by? It's defined by reducing isolation. So when we plant those seeds, we are helping. We just, it may not appear to us directly, but reducing that isolation absolutely makes an enormous difference in the lives of survivors. Multiple research studies have shown that the #1 factor for supporting resilience is the presence of loving, caring adults for kids. And so for those of you who are working with case management and working with families over the course of time, that person is you. So I want you to remember that just your presence in folks' lives makes a difference. Okay. So we're going to shift gears again here, and we're going to look at reframing our work around families, around intimate partner violence in families with health equity as a lens to understand maternal mortality, mandatory reporting, and ways forward. I have been doing this work for a very long time, and we had a national curriculum at Futures Without Violence called Healthy Moms, Happy Babies. Some of you may have been trained in it. And we decided to sunset that curriculum and replace it with this new curriculum because it was time, because the field changes, because we learn things as we go. And I wanted to just call out some of the things that we've been learning as we go in this work. Just the name of the other curriculum, Healthy Moms, Happy Babies, left out birthing people. So in part of our, focus on what we can be doing to make a difference in the lives of survivors, and then looking at maternal mortality disparities, we want to be looking at institutional racism and implicit bias. We want to be thinking about maternal disparities and birthing outcomes, and we want to continue to shift to a prevention and a community-based support framework. So that means moving away from the traditional medical model in some cases, and I'm going to show you some of the research behind doing that, the power of doing that as we move forward. The recognition of bad outcomes associated with IPV. There's been over-system involvement that disproportionately impacts families of color. And that's something that we need to be thinking about. No longer labeling folks the perpetrator, but people who cause harm can change, and really holding on to that space. We talked about that, the positive framework that we're thinking about. Hope is part of that, change is part of that. And we're going to talk about working with folks that have historically used harm in relationships and strategies to help those folks. And then, we talked about ACEs earlier. So one of the things we know is hurt people. And seeing the big picture of intergenerational trauma, and also seeing the big picture of resilience, I think can really make a difference. So that's kind of the framework that we're coming from as we enter this next part of the curriculum. I think it's important to call out mandatory reporting of IPV to child welfare. And I want to show you a huge study that was done in 2020 that illustrates the impact that had. Oops. Oh. Oh, can you see my screen?
Yeah, we can see your screen.
Okay, so what I see is something not my screen. So I'm going to stop my share just so I can see my own screen. I don't know what happened there. Sorry about that. Go this back to where we were. I don't quite know what happened. So forgive me. We were here. From current slide. Can you see it now, Kelsey, still?
Yep.
Okay, cool. So this is data looking at mandatory reporting of IPV to child welfare. And I want you to notice that the majority of participants said that the report made the situation worse or it had no impact. So we see here that of the 2,000 folks that were involved in this study, half reported or said it made the situation much worse. 12% said it made it a little bit worse. 20% said no different. 15% said a little better, and only 3% said much better. And I think this is really important, and this is part of the national conversation that's happening, and one that I want to share with all of you, because I think it's something that at the federal level and at state levels, folks are taking into account. And so from that original study looking at over 2,000 folks, they went ahead and looked at quantitative data from about 341 folks. And for participants who were warned about mandatory reporting, 60% said the warning changed what they shared to the person who issued it. So qualitative responses revealed that for nearly a third of participants who changed what they shared, the warning led them to withhold information or misrepresent their experiences. I did not disclose the most important problems, domestic violence and abuse. I left out any physical parts of abuse toward children. And so one of the things we're going to be talking about is the power of universal education. And I think that I want you to hold that in your hearts as we're moving forward, because I think this data is something that we can't ignore as a society and as healthcare providers. I think too that we want to really understand the disproportionality and the historic and systemic oppression that shapes our responses. So folks of color are often seen by systems as a problem rather than a source of protection and resilience. At least half of child welfare caseloads involve domestic violence, but that system is not structured to address domestic violence. We need to fix that. The people most impacted by child welfare systems are low-income Black and Brown, Indigenous women and children. About more than half of all Black children and their parents will experience a child abuse or neglect investigation. These interventions, the interventions the child welfare system imposes frequently do not address or solve the actual challenges parents and children face or improve their well-being. The interventions themselves can create new trauma and can undermine protective factors for children. And again, if you're interested in more on this, there's a whole series nationally of something called the Accountability Dialogues. So this is a series, webinar series where folks are really thinking deeply about how to make changes in the system. And here's a quote from Selena Hernandez, who experienced these negative outcomes relative to reporting. They did not hear me. They did not work with me, for me, or trust me. I took many protective actions for my children. No one asked me about them. I was a good teen mother who had her parents' support, yet I was being stereotyped as a bad mother. And she's being stereotyped as a bad mother because she was experiencing abuse from her partner. So I'm asking to hold all that because one of the tenets that I know everybody's engaged in here is thinking about health equity. And I think health equity means social justice in health. And for those of you who maybe haven't thought about what that definition looks like, I'm going to go ahead and share Braverman's definition from 2017. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education, housing, safe environments, and healthcare. And I want to talk about some concrete examples. I'm going to go ahead and use the state of Illinois as part of the big picture thinking that I'm sharing with you today, because I think the field has truly shifted in the last 10 years, 5 years in particular. So I'm going to use this as a case study, and then I'm going to unpack it for you. So in Illinois, this is their statewide data. In Illinois, non-Hispanic Black women are 6 times as likely to die of pregnancy-related conditions as non-Hispanic white women. Black women are about 3 times as likely to die within a year of pregnancy as women of any other race or ethnicity. Homicides accounted for 15% of all pregnancy-associated deaths for Black women. In contrast, homicide was a very rare cause of pregnancy-associated death for white women. Now, if you had shown me this data 10 years ago, maybe even 5 years ago, I would have said, well, I wonder about poverty here. I wonder if that explains some of this. I want to show you now how my thinking changed in 2018 because of this New York Times article. The article was titled, Why, set my picture down here so I can read it. Why America's Black mothers and babies are in a life or death crisis. The answer has to do with disparity in death rates, has everything to do with the lived experience of being a Black woman in America. So as I talked about how important it was to look at implicit bias, how we can set up systems to address that, slow down our thinking, this article looked at not just poor or women who had less access to healthcare, those kinds of things. It looked at middle-class Black women as well. And what we found is that the disparities, the maternal death rates, all of those things look the same. And suddenly we have to see this for what it is, right? So this is institutional racism that's happening, and it's happening in healthcare. And what are we going to do about it? And I think that history of sort of saying, well, this is about folks living in poverty, we can't do that anymore. We know too much to do that. So that means we have to make and take action steps within our programming, within our systems, within our communities, right, to fix this, because it's something that is fixable. So I'm going to share with you a fabulous doula. Her name is Miriam Zoila Perez. This is a TED Talk she did, and this TED Talk is dedicated to what actually helps, what works, what addresses these disparities in maternal mortality for Black and brown women. And I'll just share her wisdom.
But here's the thing, this problem that racism is making people of color, but especially Black women and babies sick, is vast. I could spend all of my time with you talking about it, but I won't, because I want to make sure to tell you about one solution. And the good news is, it's a solution that isn't particularly expensive, doesn't require any fancy drug treatments or new technologies. The solution is called the JJ Way. Meet Jenny Joseph. She's a midwife in the Orlando, Florida area who's been serving pregnant women for over a decade. In what she calls her easy access clinics, Jenny and her team provide prenatal care to over 600 women per year. Her clients, most of whom are Black, Haitian, and Latina, deliver at the local hospital, but by providing accessible and respectful prenatal care, Jenny has achieved something remarkable. Almost all of her clients give birth to healthy, full-term babies. Her method is deceptively simple. Jenny says that all of her appointments start at the front desk. Every member of her team and every moment a woman is at her clinic is as supportive as possible. No one is turned away due to lack of funds. The JJ way is to make the finances work no matter what the hurdles. No one is chastised for showing up late to their appointments. No one is talked down to or belittled. Jenny's waiting room feels more like your aunt's living room than a clinic. She calls this space a classroom in disguise. With the plush chairs arranged in a circle, women wait for their appointments in one-on-one chats with a staff educator or in group prenatal classes. When you finally are called back to your appointment, you're greeted by Alexis or Trina, two of Jenny's medical assistants. Both are young, African American, and moms themselves. Their approach is casual and friendly. During one visit I observed, Trina chatted with a young, soon-to-be mom while she took her blood pressure. This Latina mom was having trouble keeping food down due to nausea. As Trina deflated the blood pressure cuff, she said, "We'll see about changing your prescription, okay? We can't have you not eating." That "we" is actually a really crucial aspect of Jenny's model. She sees her staff as part of a team that, alongside the woman and her family, has one goal: get mom to term with a healthy baby. Jenny says that Trina and Alexis are actually the center of her care model, and that her role as the provider is just to support their work. Trina spends a lot of her day on her cell phone texting with clients about all sorts of things. One woman texted to ask if a medication that she was prescribed at the hospital was okay to take while pregnant. The answer was no. Another woman texted with pictures of an infant born under Jenny's care. Lastly, when you finally are called back to see the provider, you've already taken your own weight in the waiting room and done your own pee test in the bathroom. This is a big departure from the traditional medical model because it places responsibility and information back in the woman's hands. So rather than a medical setting where you might be chastised for not keeping up with provider recommendations, the kind of settings often available to low-income women, Jenny's model is to be as supportive as possible. And that support provides a crucial buffer to the stress of racism and discrimination facing these women every day. But here's the best thing about Jenny's model. It's been incredibly successful. Remember those statistics I told you that Black women are more likely to give birth too early, to give birth to low birth weight babies, to even die due to complications of pregnancy and childbirth? Well, the JJ way has almost entirely eliminated those problems, starting with what Jenny calls skinny babies. She's been able to get almost all her clients to term with healthy, chunky babies like this one. This is a baby girl born to a client of Jenny's this past June. So a similar demographic of women in Jenny's area who gave birth at the same hospital her clients did were 3 times more likely to give birth to a baby below a healthy weight. Jenny is making headway into what has been seen for decades as an almost intractable problem. So some of you might be thinking, all this one-on-one attention that the JJ way requires must be too expensive to scale. Well, you'd be wrong. The visit with the provider is not the center of Jenny's model, and for good reason. Those visits are expensive, and in order to maintain her model, she's got to see a lot of clients to cover costs. But Jenny doesn't have to spend a ton of time with each woman if all of the members of her team can provide the support, information, and care that her clients need. The beauty of Jenny's model is that she actually believes it can be implemented in pretty much any healthcare setting. It's a revolution in care just waiting to happen. So these problems I've been sharing with you are big. They come from long histories of racism, classism, a society based on race and class stratification. They involve elaborate physiological mechanisms meant to protect us that, when overstimulated, actually make us sick. But if there's one thing I've learned from my work as a doula, it's that a little bit of unconditional support can go a really long way. History has shown that people are incredibly resilient, and while we can't eradicate racism or the stress that results from it overnight, we might just be able to create environments that provide a buffer to what people of color experience on a daily basis. And during pregnancy, that buffer can be an incredible tool towards shifting the impact of racism on generations to come. Thank you.
So I'm going to stop there and just do a check-in. Anything stand out about the data that was shared with you, about Zoila's presenting of the JJ way for you? Is that new information? Is this something that you're already engaging in? Is this something just temperature check? I'm curious to hear. And if you want to come off mute, that's great. Or if you want to drop in the chat. That baby is adorable. It is adorable. I just kind of want to chew on it. Yes. Thank you. Other things that are standing out to you?
I would like to comment. I definitely could resonate with that. Even, being someone that has private insurance, a Black woman who's also had Medicaid at one point when I was in college, the differences in your insurance and the office that you're getting service at is huge. It's like you go to, and this is my experience, so it may sound critical, but you go to a community health center. At the time when I was at Northeastern, I went to Whittier, and you're late for your appointment by 12 minutes or 15 minutes, and you just get like berated, depending on how that person's feeling that day. But then you wait for a provider for 2 to 3 hours. But when I go to private practice, it's smaller. I'm greeted. You might be friendlier, might be less friendly, but it doesn't feel as institutional. I come in, my provider's closer to on time. And those little things, those interactions of the person giving you their name when they're taking your blood pressure and saying like, oh yeah, we're working on this, or you're even updating you that the provider is waiting, that you'll be waiting or that you're late, it changes your whole visit. I've also had visits that you become so frustrated that they're like, oh, your blood pressure is like, above not your regular. I'm like, yeah, do you know the stress I just went through to come here? From parking to at the front door, seeing security in certain places where other places there is no security. And I can't speak for, the well-being of the organization, and maybe they need security for whatever reason, but seeing all those in place, it definitely, puts you at a more anxious level, and then your doctor is rushing because now they're late and you have like 5 minutes. Mm-hmm. And the problems you had a week ago or a month ago, you didn't really get to process that because now you're stuck in the parking lot or the transportation. And I see that with our families that we work with. A lot of times I'm like, you have to understand how, if they take public transportation, how long ago their visit actually started, or how long ago their experience actually started. It didn't start when you popped open the car and drove. We had an event last week and they were in the heat wave and they had to take the bus, and then they had strollers. Like all of those add little stressors that I feel like as providers, we should kind of not, like they said, the visit happened at the front door. We should think about that. And also that the visit happened even before, and how the appointment was made and all those little things. So I really appreciated those comments because, yeah, I felt that in a lot of different ways. So thank you.
Well, thank you for sharing your personal journey with us too. So I really appreciate that. And, I do think this is fixable. You were talking about situations where there's a long wait. Well, let's fill in that time, right? With a health educator, with Trina that was talked about in the JJ way. There was a bunch of things that happened in the chat, I will just say, but I was so focused on the story, I didn't listen. Kelsey, maybe you could help me kind of go back to the chat. And James, you have your hand up, so I'm gonna call on you. Kelsey, take a look at the chat because I don't want to lose anything that's important. But I'll go ahead and call on James. Thank you, James.
Hey, yeah. So I hear you in saying that it's fixable, but I guess for me, I'm being a little pessimistic now. But right now, socially, politically, for a lot of people who are in power across the United States, you're talking about adding things into maternal health care, but there's lots of people right now who are trying to reduce or take away some of these things, if you will. So I always fear, when we have these types of conversation that the people who are on this, on this Zoom, who are engaged in the kind of work that we do, obviously we get it and we're sharpening our skills. But for the people who really need to hear these kinds of things and who this needs to sink into, they don't want to hear it. They have the power not to hear it, and also have the power to limit resources that we want to provide. So, again, I hate to sound a little pessimistic, but I just, that's just kind of what's on my mind.
Fair. And, honestly, part of the reason we created this curriculum is because we wanted to have this be part of the national conversation, to kind of create some tension around, if we know how to reduce maternal mortality, we say that we're interested in that, or we say we're interested in centering equity. We know how to do that, right? So let's change the way that we're laying out how maternity care is happening in community health centers. And you're right, as individuals, we can't change whole systems, but there are people on this call who can. And there's people out there in the world who can sort of think through, well, if we are really interested in reducing this disparity, if it's a goal of our system, of our hospital, of our home visitation program, of our whatever the system is that we're talking about, there's a counter to, well, okay, so let's do centering birthing care. Let's do the JJ way. Let's never shame anyone for being late for an appointment. So I hear you. We are coming from huge systems that have not listened, but I do feel like a national conversation about this is a step forward. And I'm hoping when I come back in 10 years, I can say that there were X number of these programs opened across the country, but just calling it out for what it is, which is exactly what's happening around the child welfare piece of it, is a way forward. Kelsey, was there anything in the chat that we should know, or there's so many, I can't even begin to break it down.
Yeah, there's some call outs to the value of midwifery care. There's some parallels drawn between the JJ Way model and centering pregnancy, as well as other sort of traditional community-based models of care. And then there's some folks talking about how difficult this is in a healthcare setting.
Yeah, no, I hear you. And, this is incremental, and I'm not pretending that it's magically going to happen with some, magic wand somewhere. But I do think that having a path forward is part of success. So I'm gonna just mention and call out doulas one more time, because the other place we see high rates of maternal mortality are among Alaska Native Indigenous women. And so here you can see an example of, again, sort of going back to community roots. This is Nicole Gonzalez. She's performing a smudging ceremony at a doula training. Smudging cleanses the body by burning herbs and plants in a shell, fanning the smoke around the person like a smoke bath. I mean, again, the idea that we are taking time, that we are listening, that we are embracing, and that we are nurturing and loving, the clients that we serve is part of what we're seeing here and being taken back here. I also want to mention some other national strategies that are happening that I think have a lot of hope associated with it. So both in San Francisco and in New York City, there's new programs. So rather than deciding for people what they need money for, they actually are giving $1,000 to pregnant women to help them in whatever way they need help with. So if they need to pay their electric bill because suddenly it's higher because it's 106 degrees in New York City. Okay, maybe it's 106 in Austin, Texas. I don't know how hot it is in New York City, but I know it's that hot in Austin. So suddenly they have to pay more for their air conditioning or their electric bill. So being able to make decisions about how and what they need has been shown to have really positive outcomes we saw how smart the mothers were in terms of what they did with the money. Trusting them to do what they needed to do for themselves and their family felt like a great solution to us. So I want to share that because I also think that this kind of thinking is taking back spaces to make sure that women are listened to and mothers are listened to and birthing people are listened to. And if we really want to support them, you know, thinking about giving them autonomy to support in the ways that they need support. I also want to just take a minute and talk about the history of intimate partner violence and the ways that we put people into boxes, right? And while folks can have all kinds of different partners, you know, women can have female partners, et cetera, you know, we have historically tended to sort of create a box around who is the person perpetrating violence. And it has created this perpetrators over here, survivors over here mentality, when in fact, right, the truth is, for any of you who are doing work with families, is that things get complicated. Often people stay in relationship because they're, to some extent or another, because there's a child involved. And I think that there are long-standing histories of structural racism and how it's impacted families with higher incarceration rates among men of color, but also, you know, systems that have said Black fathers are not involved in their children's lives. And sort of this is another piece around taking back that narrative and thinking deeply about how we can be engaging fathers as part of the work that we do.
I'm a fatherhood scholar and practitioner by training, and I found myself doing work in the home visiting field with African American fathers throughout the metropolitan area of Atlanta, Georgia. One of the things that immediately struck me was that a vast majority of the services were being offered to mothers and their children. I think a part of that exclusivity had a lot to do with a cultural stereotype that views Black fathers as absent from the household. My passion and my love for the work that I do around fatherhood has everything to do with me becoming a young father at the age of 15. By the time I became a professional, it was very important for me to think about how I can support other brothers and other fathers to help ensure that their needs are being met. There's this tendency to conflate paternal presence with paternal involvement. We should use our imagination to really build out an ecosystem of support that will allow us to effectively engage Black fathers who may not be residing in the same household with their children, but they have every desire to be involved in the development of their child. When I focus in on Black fathers in particular, I just think about the many obstacles that we attempt to overcome that prevent us from being the type of parents we desire to be for our children. Black fathers who may be coming from communities and neighborhoods that are ripe with violence, the punitive and racially discriminatory criminal justice policies that we have, and how Black men, many of whom are fathers, have been overrepresented in the criminal legal system. Employers who view you as untrustworthy because of your incarceration history, they're trying to climb up in a society that continuously tries to keep them at the bottom. I think there should be more formal trainings that home visitors engage in, specific to implicit bias, to understand what situations may trigger the biases that they have towards fathers generally and Black fathers specifically. I also believe there should be more training around cultural competency and how to appreciate the various cultural expressions of Black American family practices. We have bad policies that create an atmosphere that unfortunately does not allow Black fathers in particular to be the type of fathers they truly desire for their kids. And that's something that has to change.
So we've talked about a lot of things, and you just got to see that video on fatherhood. And I know some of you are truly focused in maternal care, but I also know some of you are doing home visitations. So I've been trying to keep a balance between the two things, but I think that engaging with fathers is an important part of the story that we don't necessarily always highlight. So again, I'd love to hear what stood out for you about the video or about our last little bit of conversation. And then we're going to go ahead and take a break. So anybody want to share out their thoughts here? Any other pieces? And you're welcome to talk about it in the chat. And I see someone's hand is maybe raised. Is that true? Oh, Sarah, I see your hand.
Hi, I think there's something that like I've recently learned at a childbirth education class that I run. A father, this was his second child, but this was his current partner. This was her first, and he talked about how even though he wasn't with his first child's mom, that he had a lot of stress seeing her go through postpartum and didn't know how to assess that. And like he saw that that was a huge problem and it affected not only her, but their child's well-being too. And I think that, even though fathers may not be present, I thought that was an amazing, even though we equate presence with fatherhood, that may not always be applicable to everyone, and that fathers have a role in not just maternal health, but infant health, and then also the whole family unit.
Yeah, thank you. Thank you for that, Sarah. No, I really appreciate that. And I see, and I want to be careful about, I think is it Lucia? Did I get that right, Lucia, with your hand up?
Yes, it's Lucha.
Lucia, I'm sorry. Lucia.
No problem. Thank you. This is Lucha. I'm calling in from New York City. I just wanted to note that, maternal care or birthing person centered care, it also includes, ensuring the health of the community that's supporting them, full time, whether it be their partners or extended family, neighbors, and their older children, and all of that. I think this holistic. So, making sure that their partners are well too, or their co-parents are well, is also ensuring, is also supporting the birthing parents' health.
Yeah,
that's all I want to say. Thank you.
We're talking about seeing the whole picture, right? It's not, we got to stop breaking people into parts and see them as whole folks who are part of families and communities and systems, and think about how we can use our power when we can to better support that all the way around, right? So I really appreciate that. Is there anybody else? And I'm going to just ask my friend Kelsey again, because I want to focus when someone's speaking. I'm not looking at the chat box. Is there anything in the chat that we should highlight before we go to our break?
A couple people just sharing fatherhood programs within their organizations, and just emphasizing the importance of engaging fathers and appreciating this section of the training.
Good. Okay, so here we are gonna you've learned a lot and you've been patient and we've been on a journey together. So I really want, I'm hoping you can take a solid 5-minute break or maybe even a little longer. So let's go a little longer. And Kelsey, I'm on the West Coast. So I would say we could go to like 10:45, but what is that your time?
That is 1:45 our time, Eastern.
1:45 your time. So I'll give you a couple extra minutes and I'm hoping that you can just really take a break. If you can't, that's okay, but I'll be interested to hear if you were able to do a little self-care, take this in a little bit as you take your break. Thank you. Okay, well, I think we're at time. So I want to hear from folks. Did you take a break? How did it work? Oops. What were you able to do during your break? Love to hear from you. And while I'm waiting to hear back from folks about their break, I want to share with you something. I failed and I worked on my break. You're looking into the fan, made some tea and hugged my kiddos. You're not alone in failing, by the way. Water, work, refresh. Snuggles with dogs, couple of stretches. I'm going to tell you what I did. Look, peanut butter toast. Yep. Heat up food, working from home. Okay, well, good. I'm glad some of you had an opportunity to take a little bit of a break. Okay, so we went on a journey. We were looking at sort of equity issues. We were thinking about solutions. And so now I want us to sort of take some of that thinking about how we reduce implicit bias, how we center equity in the work, and really apply that to intimate partner violence. So I'm going to ask you to share out in the chat the answer to the question why. So let me set up the question why. How many of you have personally or know someone who has ever left something out of a medical history or intentionally misreported information to their healthcare provider or home visitor? I'm going to bet all of you do know someone. I certainly have left things out of things for my healthcare provider. I can tell many stories about that. My question to you is why? Why do people leave things out of their medical histories and don't share? Judgment, trust and safety, stigma, fear of being reported, fear, don't want to be too much, stigma, fear, absolutely, fear of losing resources, exhausted, it will be left for everyone to see, shame, avoid conversation, shame. You know, if you're in a small rural community, I think there's a real fear around confidentiality and everybody knowing. Not sure what I'm here for, insurance reporting. I don't think it's going to get addressed anyway, so why bother? I really appreciate all that. And, you know, someone mentioned it, fear of reporting, and, you know, that I think is a parent's greatest fear. And we learned earlier about the prevalence of Black and brown children in the child welfare system, and about, you know, recognizing that that many people who have had the experience of intimate partner violence shared with child welfare had worse experiences as a result of that. So I want to share a little bit of data to kind of frame what we know around intimate partner violence. So this is qualitative data from clients. If mandatory reporting were not an issue, she'd tell the nurse everything about the abuse. I say no when my home visitor asks about abuse because that's how you play the game. People are afraid of social services. That's my biggest fear. Like I was saying about my friend, the reason she don't disclose is because she thinks the nurse is going to call children's services. So she avoids the nurse a lot. So let's think about that for a second. You just told me all the reasons why people don't tell us their story. And yet many of our systems are set up, remember in that deficit framework, let's measure all bad things, with screening tools like, have you been hit, kicked, slapped, or choked by a current or former partner? There's many different kinds of evidence-based screening tools out there. And here's the way it works, right, traditionally in clinic. If you ask me, Rebecca, have you ever been hit, kicked, slapped, or choked by a current or former partner? I'm going to say no. And you say, okay, great. And we go on to the next thing on your list, right? But I want you to think about that, because as we have set up our system, even though we know people can't tell us their story, the only people we're sharing resources with are people who say yes. And if we're really thinking about equity, if we're recognizing that people can't tell us their stories, especially those who've been, system involved, marginalized, have had bad experiences with healthcare in the past, then we have to reframe our work and change the way we do what we do, right? So screening questions obviously leaves a lot of people behind, right? You looked at the data earlier about how prevalent intimate partner violence is in the lives of women and birthing people, because that's who we're talking about today. And I'm going to guess your positive disclosure rates in your practice doesn't look anywhere close to 1 in 4. Not even close, right? Probably closer to 1 or 2%, maybe a little higher if you're having more conversations. So clearly we are leaving people behind in the ways that we do what we do, and we want to address that. I also am going to use my friend Kelsey. Kelsey, I didn't tell you I was going to do this, but do you mind coming off? Coming back on screen. Hi, Kelsey. So let's say you're in Berkeley and you're in my backyard and we're having lunch today. And I'm going to make you a tuna melt because I love a good tuna melt. And you're going to say, that was the best tuna melt I ever had. And I'm going to say, thank you. And you want to know what the secret is? And you're going to say yes. And I'm going to say capers, which is true. That's a little caper juice, little capers in tuna salad, egg salad, delicious. And then I'm going to say, so do you want more tea? And you're going to say, sure. And then I'm going to say, so does Jeff ever hit you, choke you, hurt you in any way? Now, I'm asking you this, Kelsey, because can you imagine me, after talking about caper juice, asking you a direct screening question about, is Jeff hurting you? No, right? No. What I might say is, hey, last time we talked to you and Jeff were kind of having like issues. How are you? How are you doing, right? I'm going to ask you in a way that's relational. I'm not going to ask you in that way. And I want us to really think about what we know from the research and what women tell us, right? So here's what we know from nurse family partnership data. The use of structured screening tools, so have you been hit, kicked, slapped, or choked, or something along those lines, at enrollment does not promote disclosure or in-depth exploration of women's experiences of abuse. Women are more likely to discuss experiences of violence or difficulties in their relationship, power and control, when the nurses initiate non-structured discussions, right, about parenting and safety and healthy relationships, and you tie it into, right, the relationship you have, as opposed to asking that direct screening question. So we know that universal education really allows us to center equity in health, right? Universal education provides a strategy to treat clients with respect by giving them key information about healthy and unhealthy relationships and where to go to get supports without requiring disclosure to get them. I know, and I don't want you to lose funding, and I know we don't have control over changing systems yet. So if you're required by your program to use screening tools or to do this in order to get paid, in order to meet the goals of your program, I'm not saying you shouldn't do those tools. I am, however, suggesting prior to doing any screening tools, you do universal education, because what it allows you to do is have a transition, a segue to that more direct question. And also our overall goal of not leaving people behind. So Sarah is going to drop, or not Sarah, Kelsey's going to drop into the chat this tool. It's called Connected Parents, Connected Kids. And when you get it in the chat, it's going to look a little funny. I want to orient you. So it starts with in the center of the card, because this is a PDF that's set up for printing. It's not set up in the way that you would want to read it, but it's set up in the way that it kind of unfolds. So I'll show you here how it kind of works. So you want to start with a panel in the middle that has the image. And then you're going to start with You Matter, going down the panels that way. And then you go back up to the top of the card to look at the other panels, ending with the resource panel. So I know that's the way it's laid out is a little wonky, but I wanted to give you a second. So take a minute, read through the card, and we're going to notice together what comes up for you. And when you finish, if you wouldn't mind giving me a thumbs up. And Kelsey, if you could be my eyes and ears, if people are putting their thumbs up, if you could just give me a temperature read, that would be helpful.
Got a couple. We've got 3 or 4.
Okay, we'll give it some more time. Okay, so while folks are finishing, kind of looking at the card, I'd love to hear thoughts. What did you notice? And you can come off mute or you can share that in the chat with me. Things you noticed. Or things you liked, things you didn't like. Bernice, I see your hand. Go ahead and unmute yourself if you want to share. Oh, maybe Bernice just said she's finished her reading. Maybe that's it. Anybody else? Margie, you said, looks like good info, but it makes me wonder what the goal is or who's sponsoring the wording. Interesting. So I will tell you that we developed this in concert with home visitors across the country, with folks who were leaders in home visitation and maternal care. It's been tested, talked through, looked through, and the goal of this card is a 3-gen approach. We wanted in COVID, one of the things that happened around IPV is that we realized we never knew who was in the Zoom room. We didn't know for sure if anybody was alone. So that really changes the game when it comes to screening for intimate partner violence. But also because we've been rethinking that long history of system involvement and knowing that the child welfare, the IPV being, something that's shared with child welfare has not necessarily been helpful to families at all, actually quite the opposite. We wanted to have an approach that was universal for all comers. So we talked to everybody about this, right? It could be aunties, grandmas, et cetera. You see that we nestled adverse childhood experience information, difficulties in childhood, the ways that affect your health. We talked about You Matter, right? So it talks about healthy and safe relationships. It talks about complicated relationships and talks about the hotline. And the idea behind this universal education approach is that we make sure that we don't leave anybody behind, because we know that people who are being harmed need supports, but also people who use harm might want to change. So I want to show you how this intervention works. And it's pretty straightforward. So there's lots of panels on the card, but if you're wanting to talk to your folks about intimate partner violence universally, I want to give you a way to do that, right? So here's the opening for the CUES script, and CUES stands for Confidentiality, Universal Education, Empowerment, and Supports. And you can see how we would open with this script. We're giving these cards to all the families in our program. They have great info on how to build healthy homes. We give you 2 cards, or you can share it electronically with a QR code. So you have the info for yourself, but also so you can help friends or family. So you can see that there's a QR code here on the next panel. And if you put your phone on that QR code and you put it in your camera, it will take you to the card, which will allow you to forward it to somebody else. So the script continues. In this card, it's like they're kind of breaking down the real stuff in people's lives that we don't always talk about. Like laying out what helps families and what people deserve, like being treated with respect and kindness, being listened to, feeling safe, and being supported in your parenting. This is incredibly important because given the prevalence of adverse childhood experiences, it may be that no one's had that modeled for them. Your client may not know that they deserve those things because their mom didn't get those things, or because nobody treated each other that way in the home. So it's really important that we are doing universal education both around healthy relationships and then ones that are complicated. And we were very specific around this language. You can see we didn't use intimate partner violence, we didn't use domestic violence, we didn't use abuse. We used the language that survivors use, and the word complicated comes up a lot when folks are talking about things, because labels, you can't change labels. That was part of the thing with ACEs, right? I can't change my ACE score. So the whole thing about, are you an abused person? Are you experiencing intimate partner violence? None of that language particularly resonates with clients. It's something we talk about professionally, but it's not what we would do in real time with folks. So I want to continue with the script here. The other piece I wanted to share is all relationships sometimes get complicated or hard. Like name calling, fighting, or other stuff that may be controlling us or hurts us emotionally or physically. This card helps us talk about how common relationship stress and problems are and what helps. Talking about it is so important because kids and babies need parents to be in the best possible space when things are rough, and supports can help. So here again, we've talked about something that is true. It's relationships can be complicated. We were very intentional about that relationship. As I mentioned before, in Zoom, we didn't know who was in the room, but we certainly wanted to make sure that people had key information without sort of saying, I need to whisper something in your ear in the corner, but rather just sort of in a broader way. We've been doing research on this approach, and maternity hospital. So after the baby's born, you know, you have partner there, auntie there, grandma there, all the people there. And so like screening for intimate partner violence in that context is like, what? How do you do that other than saying, everybody out? I need to have this conversation. We wanted a way to bring everybody in, going back to this idea of community health, of seeing a whole family, of talking about what people deserve and talking about the realities that things can be hard. And then let's talk about what works. So we continue the script. Here are free anonymous 24 helplines on the back of the card. You can share them with friends and family too. They have trained advocates who aren't judgmental. They give you support and advice for complicated relationships, both for people who are being hurt and those that cause hurt. Also, there's a supportive parenting helpline for times when you're feeling overwhelmed or frustrated with your child. So what have we just done here? We have said, we've normalized the fact that relationships can be complicated, that there are supports available for both parties, those who are being hurt, those that are experiencing hurt. And sometimes that can happen with both parties, right? So we want to be able to be inclusive of where supports can come from. So you can see how you can tailor this, right, depending upon where you are. If you're in a clinical setting, you're alone with birthing person or mom, you're going to have a more sort of targeted conversation around the universal education. Hey, I've started sharing this with all my clients, right, instead of with all my families. Or maybe you want to share it with all your families and say, you know, this is something you can share with your partner or your, you know, mother-in-law or whomever. So what do you think happens when the card gets framed this way, or when you talk about the QR code and the electronic tool that you can send to someone? We're giving these cards to all the parents in our program. They have great info on how to build strong kids and healthy homes. We give you 2 cards so you have the info for yourself, but also so you can help friends and family. What do you think happens when we start our conversation that way? It reduces stigma. I love the card. It's much safer to hand this to someone in a home visit. Very much so, Rochelle. Yeah, it reduces stigma. It opens the door to conversation. It recognizes that some people can't tell us their truth. I know someone who's going through this. Yes, I mean, and we're going to see examples of, sometimes I bet you wonder if someone says, I know someone who's going through this. Is it them that are going through it, or is it someone else that's going through it? It could be that that's their way of getting more information from you. It opens the door to future conversations, absolutely. And this is what our research tells us too. Exactly, it's okay if we never know. Yes, amen. But also you've said, hey, I know this is a real thing, and you can follow this up with, so I just want you to know I'm here as a resource, or you can see why this would be such a cool way if you have to screen, have you been hit, slept, or choked, as a segue into any screening tool you have. It changes the nature of the way you're holding it. So the card is being translated into Spanish right now. It's like any second now. We've taken it through a really rigorous process so that we're not just doing a direct translation. We're actually taking it to the people who speak Spanish and saying, okay, does this work? How does this language work? And looking at it with folks who are from Mexico, folks that are Spanish speakers from other places, and making sure it all works together. So any second now. Okay, so what do we know about cues? We know from our research that it builds relationships between providers and clients, that it's strength-based and caring focused. It focuses on altruism. So this idea that you can help another person, you, the client, can help another person is really key, right? So here's some research that supports why altruism is so important. The power of social support is more about mutuality than about getting for self. That is, there's a need to give, to matter, to make a difference. We find meaning in contributing to the well-being of others. You all do that, right? You're doing this work because you want to help but your clients want to help too. And I want you to think about this through the lens of someone who's being told they're worthless, they're useless, nobody wants them, nobody would ever hire them. And the power of you saying, hey, this is something you can share with somebody else, because you're saying, I think you're someone who can do that. So just the transfer of power to that client really makes a difference. Obviously, it improves access to advocacy because everybody knows where to go to get help and supports. It's on the back of the card. It empowers clients and the folks that they care about. So I think that of this is, if we're trying to change community norms, we're trying to work within communities and be partners in communities, that this is a way to do that, because it's about the people, for the people, by the people. And it shares power between the provider and the client. And here's what folks said about other cards. The card made me feel empowered because you can really help somebody. So this is coming from a provider. You can really help somebody that might have been afraid to say anything or didn't know how to approach the topic. This is a door for them to be open so they can feel more relaxed about talking about it. This is what the client said. They would bring out the card, basically walk in with it. She'd open it up and ask me if I'd seen it before. It was awesome. She'd touch on, no matter what situation you're in, there's something or someplace that can help you. I didn't have to be alone in it. That was really huge for me because I was alone most of the time for the worst part. So this tool also reduces isolation. Remember, back to the beginning of today, that's our goal, is to reduce isolation, right? With the folks that we're serving in maternity and birthing people care. Getting the card makes me actually feel like I have a lot of power to help somebody. So we know that clients love the idea that they are enlisted in helping other people. So my clinical friends, this is an example of an OBGYN setting. And I'm going to fast forward to the sort of very brief clinical intervention so you can see it live. And this is using a different card. So this is one that's focused on reproductive health in a reproductive health setting.
One of the things we've started to do with all our patients is give them these safety cards. Even if they say their relationships are great, and even if they're not in a relationship.
Why?
Because we know that relationships change. And we also know that many women have friends and family who need help, but they don't know what to do. This card talks about what women do and do not deserve in relationships, and it has safety information and 24/7 hotlines on the back.
Thank you for these. My sister, she's been struggling a long time, and I keep trying to figure out ways to better help her.
I'm sorry to hear that about her.
Yeah, me too.
Well, I'm glad these are useful to you and possibly to her. You can call the numbers on the back for more information about how to help.
Thank you.
Do you have any questions?
No, thank you. These are perfect.
Great.
Okay.
Is it okay?
I want to know, before we get to the slide, was it for her or was it for her sister? What do you think? For her. Her. So I wrote this video and we don't know, right? So yes, I wanted people to wonder about, is it really for her? So it tilted in that direction, but it really could have been for a sister. And it shows the thing that was shared in the chat earlier, that it doesn't matter. It doesn't matter who it was for, right? So if it's for the sister, awesome, because now her sister has more tools to help her, and I'm sure she will do that. But if it's for the client in front of that provider just sowed the seeds that are going to have an opportunity to grow. She has information that she didn't have before. She knows where she can go to get confidential 24/7 help. It doesn't matter. And that's the point here, right? So let's not leave anybody behind. And, you know, again, this does not prevent somebody from sharing, hey, that's happening to me. It just is making sure that we're bringing everybody in and that they have the information if they can't share it with us. So my goal with all of you today is for you to feel confident, comfortable, and clear about how to do cues and use this tool. So, Kelsey is going to drop, I hope, this tool into the chat. And what I did to make it easy for you is, you know, getting started or using a new tool, it's always helpful to have a cheat sheet. So this is your cheat sheet. Those slides that I showed you earlier, this is the exact script next to the panel of the cards so that you have a visual reference and words, so you can have it at your computer if you're doing a Zoom meeting. You can have it on a clipboard if you're doing something in person or you're wanting to remind yourself about the scripts, or read through it before you go into a visit or before you go into a clinical interaction. So I just want to make sure, did everybody get this in the chat, Kelsey?
Yeah, so I shared both the Dropbox version in the chat as well as a PDF file for those of you that can't access Dropbox because of firewalls in your organization. There's also that PDF version. Rebecca, we did receive one question in the chat about where folks can order this card or get this card. Is there an opportunity to do that, or is it just that they should print it themselves?
Promise at the end of the talk today, because it's going to be helpful for you to have it at the end. I will tell you how to order these from Futures Without Violence. I'll give you all the info. So thank you. So hopefully everybody can open this tool. Can everybody open it? Is anybody having problems? Okay, I don't see any hands up, so I'm going to assume everybody can access it. Great. All right, so Kelsey, we're going to do our role play. I want to show you how one might do this in Zoom. So Kelsey, I don't know if you can come off. Yeah, exactly. So I'm on Zoom with Kelsey. And Kelsey, your name's Nicole today. Nicole is 20 and she's a mom of 2 kids. And so Kelsey, I'm just going to start. So Nicole, it's so good to see you. We have a lot of stuff to cover today, but before I get started with anything, is there anybody else we're going to be inviting to this conversation? Is Johan home, or is your grandma around, or is there anybody else coming to chat with you?
Nope, just me.
Okay, cool. So I'm going to share some stuff with you today, and you can always share it with them later. But before I get there, I just want to know how are you doing? What has the day been like for you so far?
It's been okay, I guess. The baby is good. She's sleeping more, so that helps, but I'm pretty tired.
I hear that, but I'm glad to hear she's sleeping more. That's a relief from last time, I know. That's awesome.
Yeah.
So one of the things that I'm going to do is share this little tool with you electronically. So I'm going to drop that in the chat for you right now and let you open it up.
Okay, cool.
What I like about this tool, and we're sharing it out with everybody, and we're sharing it so that you have the information for yourself, but also so you can share it with folks in your home and your community, friends, everybody and anybody. Okay. And what I like about it is that it talks about real stuff. It doesn't beat around the bush. It like just lays things out. And I think when we lay stuff out, it can be easier to talk about. So it talks about, on this first panel, you matter. It talks about what people deserve in relationships. And I don't think we talk about that enough, right? So being respected, being listened to, having your parenting supported, having somebody be kind to you. We know that when that happens, it helps kids thrive. And then this other panel over here, and if you just kind of scroll down on that card, you'll see that it talks about complicated relationships, because everybody has them. I mean, it's not like my relationship's perfect, right? So everybody has those moments, and the whole point is I want people to know what to do if stuff happens, right? Maybe there's fighting, maybe there's yelling. I like that it gives you simple ideas about what to do when you're upset. That's on other panels of the card. But I think it's really important that folks know that if things are hard or you're being hurt or somebody's being, not kind, all those things, that there's places to go to get help and support. So as you scroll down a little bit farther on the card, it talks about hotlines that are 24/7. And I think the thing that's different is that those hotlines are really set up for both people who are being harmed or having a hard time in their relationship, but also for people who maybe are causing that harm and maybe they want to have some changes. So, that's there for you as a support. So I don't know if any of this is resonating for you or interesting, but I just wanted to make sure that you had that info for yourself or anybody else who might need it.
Thanks. Yeah, sometimes it's hard. I mean, it's not like Sam is hurting me physically, but he can be kind of a jerk. But he can also be super sweet to me and the baby. So I don't know, it's just hard.
Yeah. No, I really hear that. I'm glad that he can be sweet with you and the baby. I'm wondering, what do you do when it's hard? I mean, what kinds of things are helping you?
I do lots of things. I really like walking, so I take me and the baby for a walk. I try to go to my mom's house. She's close, so that can be helpful. Or sometimes I just snuggle up with the baby because those cuddles always make me feel better.
Yeah, no, I hear that. And I'm jealous. I wish my mom were close. I think having another loving adult in a child's life is like huge. It makes such a big difference. So I'm so glad you have that support. I'm wondering, are you interested in other ideas that might be helpful for you and Sam?
Yeah, more tools in my tool belt is always a good thing.
Great. So like this panel of the card that says strong families might be helpful with Sam. I mean, I use this strategy with myself all the time because, truly most families want caring relationships. So like if you can notice what's happening in your body when you're feeling upset or out of control or angry, you can do something to slow it down, right? You can, take deep breaths, splash water on your face, take a break from the house. Maybe you can talk with Sam about ideas or ways that you can support him when he's frustrated or angry. And
yeah,
yeah,
maybe. I think Sam feels bad when things blow up. So I think that we could have a conversation like that.
Nice. So thank you, Kelsey, for doing that with me. I appreciate you. My friends on the phone, and I understand for my clinical friends, it might not work quite this way. I understand for my home visitation friends and case manager friends, this is probably closer to the kinds of conversations you're having. But I'm curious, what did you hear? What worked? Are the steps clear to you? And you can share in the chat or you can come off mute. It's okay if the thing that you want to say is, I don't get it. I don't think I can do it. That's okay too.
I like the casual approach though. The relaxed approach, because I think as providers, we're nervous. The answer may or may not be, but I did feel like it was just not to be matter of fact, but it was just kind of mellow.
Great. And Sarah, it was a lot of one-sided talking, you know, so you could obviously, and you would with your client that you had a relationship with, you'd take it with bite sizes in the way that it worked for you. I was just trying to show you how those scripts can work to help you. But of course, if you wanted to just talk about the You Matter panel first and then say, you know, is there anything that's coming up for you there, you could stop yourself and do that. I was just trying to help you see the sequence, but obviously, or I hope it's obvious, this is about you. This is about you making it real and right for the people you're serving, using your expertise, using your wisdom in the way that it would flow. So I don't pretend like that was exactly how it would go down. If I were having a conversation, I wouldn't do it all that one-sided necessarily either. But I wanted to give you an opportunity. I like to be a little clear on the situation so as not to encourage partner involvement quite so soon. Yeah, I think that's also a great thing to say. You could easily say, so I'm wondering, is there ever a situation, and we skipped this in the role play. I think Kelsey was supposed to say, you know, he can be a jerk, but there's nothing physical or anything like that. So that got skipped. So obviously that would have changed. That changes the way it worked. So sorry about that. You're right. I had the client disclose it rather than asking about it. So good catch. Thank you. Anything else? Okay. So what I want to do is try it. Okay. So you're going to be dropped into Zoom rooms with others, and you can use that template of the card. And you can do it at a very high level, right? So we started getting 2 of these out to everybody because it's for friends and family. You want to touch on healthy relationships, so the You Matter panel. You want to touch on complicated relationships and the hotline. Now, of course, I don't want you all to get jammed up with disclosures or difficult clients or people who are resistant or all those things, because in fact, we know from our research that folks really like this intervention. They appreciate being, you know, told that they can share it with other people. So I want you to make this really simple. I just want you to practice the scripts and then tweak them, make them your own. Sarah, if you want to take a little bit more time and start with that You Matter panel, and then, you know, again, trying to get through it, but if you want to start and, you know, tweak it. That's totally up to you. So you're welcome to use my scripts verbatim, or you can think of a mom or a birthing person and you picture them in your mind's eye that you have an established relationship with. Think about your last conversation with them. How might you start the conversation about the card with them? You know, this is authentic to your relationship with the client or patient you're serving. So really tweak it and make it your own. My goal is to have people, different people have turns. So don't feel bad if you know we don't manage to get to you in the time frame, but also, you know, make sure that we're giving enough room for other people to try this on. So what's going to happen next is Kelsey's going to drop you into chat rooms with those scripts, so you'll be able to see them. And I want you to try it and see how it feels, see how it works, and we're going to debrief it together. This is a 7-minute activity. There's going to be about 5 of you in a room, and again, we're trying to get through that script. So, any questions before we drop you into Zoom or the chat room? Questions, thoughts, concerns? Yeah.
I also will just say that I put the card back in the chat, the link to the card. I also dropped a couple, the PDF in that chat a couple of times.
Thank you. Okay, so any other questions or thoughts? And then we'll drop you into the Zoom room. Anybody? Okay. So what's going to happen if you haven't been dropped in a Zoom room before? You're going to see something that says, click to join this breakout room. So just hit yes. And you can see who's in room 1, room 2. So you want to see, find your name, scroll down, find your name, and then hit click to join. So find your name and click to join. And you can also drop folks in the exam, in the rooms too, Kelsey, if you'd like. That might be easier, Kelsey, if you can just drop them into the rooms, just break them out.
I thought I did that.
For all of you who are in this room and having technical difficulties getting into the chat rooms, I'm so sorry. I know that Kelsey was trying to put people in different rooms, so I'm sorry for the technology disconnect. And the other folks will be joining us in about a minute or so. And Kelsey, are they coming back? Oh, I see. Yep, here everybody comes. Or Kelsey, maybe you can tell me when everybody's.
Yeah, we have 10 seconds left, Rebecca.
Okay, thank you. So welcome back, everyone. For anybody who had difficulty getting into a room, I'm so sorry. I know that technology is not always the best with these kinds of things, so sorry if that didn't work for you. For those of you it did work for, how did it go? What stood out for you? Thoughts on, what happened? And you can type in the chat or you can come off mute. But were you able to do it? Did you end up spending the time just talking about the concept or your lunch? Or were you able to try it on? I'd love to hear.
So this is oh, go ahead.
Oh, sorry.
No, you could go ahead.
Okay. Hi. Me and I was able to get into the room, and it was two of us in there, and then one person showed up, and I don't think she was able to get in because we never did communicate. But we talked about the concept, and she gave some scenarios as far as a scenario of one of her cases, and kind of we broke it down and just seeing how those cards may have helped break down a barrier, because it took a while before she was able to get that breakthrough with the young lady. So we feel like those cards would have really helped steer that conversation to where it needed to be so she can get the help that she needed.
Good, thank you.
Yes, and this is Irene. So I was with Kirsten in the room, and I absolutely agree with what she said. So absolutely, the cards would have speeded up the process. Unfortunately, she's French speaking, so hopefully eventually there'll be also cards in French.
We have had many sites translate for their community because we're never going to be able to sort of translate. But like, for example, it was a Portuguese speaking community outside of Boston. And so we gave them permission to translate it. They had professional translators do it. We had it checked and then they got to run the card. So I want you to know that if you have a special population that you're working with, we might nationally not be able to do every language, but we certainly support you in doing that.
Wonderful.
Absolutely. So follow back up. Lisa Brown, you have your hand up.
I do. Thank you. We did get into the room. I was in the room with Pam, and there was one more person, but she wasn't. Something happened there, so it was just the two of us. We did do some of the role play, but we ended up moving more into a specific situation I had yesterday. I'm a doula, and so I was doing an intake with someone, and they had this is helpful because they have layered, complicated situations sometimes people do in their lives, of course. And in her case, she is high risk. She wants a VBAC after cesarean, and she just recently got out of a domestic violence situation. She has a 1-year-old who's going to care for the 1-year-old. So I thought, I actually am going to go back and talk to her about this and provide her with this. But it's just the thought of all that she has going on, and then to think, like we talked in intake, like who can get her information, like we keep confidential information. Who does she really want in the room with her when she's, something like if he were to come. So we did get some of that talked about, but yeah, I'm going to revisit it with her again.
So Lisa, you sound like the doula of my dreams. I love that so I asked you to make it real. And you know what you did? You turned around and you talked about somebody who is getting out of that situation and how you would apply. So thank you for doing that. I mean, this is here for you to create those connections and meet people where they are. And I know on one hand, I hate that I do any scripts at all, but I think it helps to have something to jump off of, right? So I love it your own. I really do. Thank you. Thank you for sharing what you do. Okay, Kelsey, I lost the chat. Is there anything that I should know about? Oh wait, I see Julie said, I can see how practicing this verbiage many times would help it roll off my tongue faster and more naturally. Amen. That's what this is about. It's practice. And I think that the more we can, think about doing this on your maternal health team, with your nurses, with your home visitation team, with your clinical consultants, my supervisor friends, building this into reflected practice, I think is a great idea. Is there anything else, Kelsey, that I missed in the chat that we should cover?
I think that was really the main comment.
Thank you. So here's the thing, right? I would love you to do this universal education with everybody, but it's not, I don't want you to do it and not pay attention to the person in front of you. So if you've got a mom with a crazy fussy baby and it's clear that she's distressed, the baby's distressed, don't have this conversation, wait, it's okay if it's not the time to have the conversation. For older kiddos, if you're going to be having a bigger conversation, I'm always going to suggest that headphones are really helpful, whether they're listening to music, for books and toys, other kinds of things. And if you don't know about this Sesame Street series, it's awesome. And it's kind of about helping little people learn how to comfort themselves when they've experienced something hard. And, of course, when I'm thinking hard, it could be witnessing domestic violence, it could be trauma, it could be trauma that happened to them. But that's a series of tools that I think are really great for kids and for parents to know about too, if they're helping a child that maybe had something hard happen to them. So with older kids, if you end up having a bigger conversation around IPV, then I think that's a really important strategy to think about, because we know that abusive partners will interrogate children that are older to say, what did the doctor say when mommy went to the doctor, kind of thing. So I think that's an important thing to note. I mentioned this earlier. We want to bring folks in. It's like, hi, I have some information. Oh, your mother-in-law's here today. Great. I want to bring her in. She can join too. I know there's situations where there's folks in the room and we can't have a direct conversation about IPV. But I do also recognize that you might want to do a temperature check. So if you're doing universal education with the whole family and you're watching an expression go across the client's face, you're going to stop with that conversation and just leave it at healthy relationships, and that's okay too. So we're going to take a second and just kind of absorb what we just learned about universal education. And I'm going to give you a break so that you can kind of, again, we learned a lot in a short period of time. So I want to honor your time, give you a 5-minute break, and then I'll have you come back. And let's go ahead and come back and just right at 11, let's do 11:52.
which is 2:52 Eastern.
2:52 Eastern, just so we have enough time to cover the rest of it. I'll see you in 5 minutes. Thank you. Okay, well, hopefully you all were able to take a break. If you want to share in the chat with me what you were able to do, including if you weren't able to take a break, that's okay too. I walked outside, so I'm and sort of had a little moment in my backyard, which was really nice. I don't know if anybody else wants to share what they did with their break. Anybody want to share? Were you able to stretch or have a cup of coffee? You're doing a puzzle. I love a good puzzle. That's awesome. It's very meditative. It's like baking bread. I love kneading dough too. So baking puzzles, baking bread. Anybody else want to share? Wordle. Okay, don't tell us, Sarah, because I haven't done it yet. Neither has Kelsey. So thank you for that. All right. Yesterday, I know that not maybe excuse me, everyone was with us yesterday. So I'm just going to do a quick reminder. We were introduced to the FAN. This is Linda Gilkerson's model out of the Erickson Institute. And yesterday was kind of dedicated to that first wedge of the FAN, that mindful self-regulation. Where are you in space and time? How are you feeling in your body? How can you come back to center if you're getting upset? All of those kinds of things. We're going to look at the whole FAN today in the context of IPV and sort of think together about how we can use that to enhance our work. I want to talk about mindful self-regulation in practice as a response to power and control and share this with you. The thing I remember is what happened when I got caught off guard. This is a home visitor. Mom shared with me that she was so glad I came today. And, you know, the home visitor had diapers, saying she was out of money and she had to wait till her partner got home to get more because he was the one responsible for the bank account. My first thought was anger. And I wanted to share how unfair that was to my client. But then I realized my big feelings. I took a breath. I pushed my heels and toes into the floor to get grounded. I reconnected with her gratitude, right? So she was saying, mom was saying, thank you so much, right? So she was saying, thank you for the diapers. I reconnected with her gratitude and what she was saying rather than what I was feeling. So this is a great example of letting the client drive, paying attention to yourself, not letting yourself get overwrought with what is getting shared, and listening to the client and meeting them where they are and taking care of yourself in the process. So I would say staying with feelings with clients is one of the hardest things that we do. So when an intense emotion or there's uncertainty present, most of us have the tendency to move away from or control the feeling. Remember yesterday I talked about you put on the cape because you want to fix it and you want to take over the conversation. So we tend to lean toward acting rather than sitting with feelings. We often rush to reassure, oh, I'm sure that's going to be okay, rather than letting the client feel what they're feeling. And by the way, I've done all these things. So if you're going, oh, I did that too. Don't, I'm saying it out loud because we're humans and it is really normal to jump to things. And remember, going back to implicit bias versus slowing down and thinking through things. If we aren't present with ourselves, it's hard to notice what we're doing in the moment, right? We jump to the next thing rather than sitting with that person and their feelings. Maybe we want to change the subject. Maybe we get emotional ourselves. So I think the FAN can really help us stay in tune with the client as we're talking with them about complicated things. So it's a structure for engagement. Again, staying in tune with the client, and it's a guide for reflective practice. And we talked about reflective practice yesterday and how important it is. If your program doesn't have it, 0 to 3 has great information on how you can learn more about it or integrate it or implement it into your program. But just quickly, reflective supervision is when you have intensive or intentional supervision that allows you to work through whatever's going on with you about a client that you're serving, or just how you're feeling generally about talking about cues, talking about IPV in a different way than you have before. It's holding space for you all as staff. So sometimes, as you saw with the healthcare provider, you have like 30 seconds, maybe 40 seconds with a client. So you can do that quick and dirty overview of the card. We started getting this to everybody. It talks about healthy relationships, ones that aren't. The reality that sometimes people are in complicated relationships. And I just want everybody to know that there's supports on the back, and this is a tool you can use for yourself if you were to need it, or with anybody else, right? Quick, quick, quick. So sometimes you have 30 seconds, and boy, I would love this to be integrated in some part of your 30 seconds with every client, because what we just did was we broke the isolation. We made sure that they had information on how to get help, and we normalized the fact that relationships can be complicated. So that was like success, success, success. There's very few things, I think, in medicine and other practices where you could say, yes, that's working. This is one of those things that is working. So I'm just going to encourage you, whether you make your script into 30 seconds or you can have a longer conversation. And Sarah, I'm going to go back to you. And you know, you're going to talk about one panel of the card, and then you're going to have a whole dialogue with the client about that. And then you're going to talk about another panel and have a whole dialogue about that. And you have more time. So I want to acknowledge that time is a real thing in medicine. And so you know, there's many ways to be successful with the card. So you can do the shorter version or the longer version. Okay, so what we want to do is look at the other parts of this fan. This is not something that is sequential, so you don't go from I'm going to notice where I am first to the clients and feeling, the clients and thinking, the clients and doing, the clients is in integration. That's not how it works. Your client can be anywhere, right? So the day that you come for that home visit, or the day that the client's coming in for clinical care, they might be thinking about quitting smoking, right? That's the first thing on their mind. So we're going to meet them where they are. We're not going to, you know, decide for them what's going on. But I think the place that I want to give you the most support and encouragement is around this feeling wedge, because that's the place that typically people feel really uncomfortable. And the idea behind this fan is if we can be aligned. So if the client's interested in making changes or doing, we're going to help them with that. If they're interested in kind of thinking through something, collaborative exploration, we're going to help them with that. If they're in feelings, we're going to let them stay there. And the idea is we are trying to strengthen parents' resiliency. We're trying to promote provider self-awareness and effectiveness, so we can promote, you know, best outcomes for health and parenting. So I want to just kind of give you some examples of those wedges of the fan, right? So feelings, knowing what to do when stuff comes up and how we can best sit with parents and feelings. That sounds hard, or I can see that you're sad. You know, noticing what's happening with that person and reflecting it back to them, and then letting them sit in that place for a little while. What are your thoughts about that? What stands out for you? If you've got somebody who's thinking about making a change or thinking about quitting smoking, right? What are your thoughts about that? What stands out for you? What are you thinking about next steps? And you know, you want to give them space to be the expert in their own experience, right? So maybe they are already doing some things that you don't know about, so you want to know about them. And then you can ask, do you want to learn more about what other kinds of things are available to you? And then doing, what are the actions that are suggested? I'm wondering if you've ever tried, or what are your strategies for? And again, we're trying to model and be in the same place with the client at the same time. And then we always want to reflect back on what we taught or what we talked to with the client about that day. I'm wondering if in our conversation, is there something that really stood out to you? So I'm just going to throw out a quick case study, and I want to show you sort of how the fan can be useful in practice. So I'm going to read the case study to you. Gabriella is a home visitor who is working closely with an 18-year-old first-time mom, Maria. Spanish is her primary language, and she's taking ESL classes at this time with a baby and a toddler in her life. So she's got a lot going on. Gabriella cares deeply about Maria because she reminds her of her own mom's story. Gabriella's mom came to the United States when she was 18 and pregnant and did not speak English. Gabriella's mom has a very close relationship with Gabriella and her sister. Maria's experience brings up a lot of feelings for Gabriella because of what she witnessed in her own parents' relationship. So today, Gabriella is introducing the Connected Parents, Connected Kids card to Maria. And here's what her script looks like, right? So you can see we've already started the conversation. We're at the point where Gabriella's introducing the specific panels of the card. I really like this panel of the card. It talks about how everyone deserves respect and kindness, and that sometimes parenting can be lonely, and it's okay to ask for help. What are your thoughts? I mean, it would be nice if that ever happened, but I disappoint him a lot. I don't know. All right, so we have an inkling that maybe things aren't so great. We want to acknowledge what Maria said. Thank you for sharing that with me, Maria. I don't know about in your family, but in mine, we weren't supposed to talk about our business. Like sometimes my mom was hurt by my dad. The reason they made this card is for people to see many of us have been hurt or used hurt to control someone else. We may need help at some point, especially, that's what that DV hotline is for on the back. It's to give free confidential help to everyone, both those that cause harm and are harmed. Maria starts crying. Things are really hard right now. We're fighting all the time. I don't want it to be this way. Gabriella says in a strong voice in response to Maria's tears, I know exactly what we should do. We see Maria's body language change. She crosses her arms in front of herself. Okay. Tell me about where Gabriella is, the home visitor.
She moved all over to doing.
She moved to doing, she put on her cape, didn't she? She totally friggin' put on her cape right in front of you, didn't she? She's like, I know what we should do, right?
Pretty much.
And Maria didn't appreciate that, did she?
And I think that's the thing I'm feeling is that I would get a level of excitement or movement, and it's very off-putting to the client. So I'm tracking with that.
Mm-hmm. And so Maria just started sobbing in front of you. And I want to go back to this little bit here. We're fighting all the time. I just didn't want it to be like this. And instead of, and we see that the home visitor in response to those tears says, I know what we should do. I'm not going to do breakout rooms because I think we can just kind of do this together. What does Gabriella need to do to rewrite the script, to do that U-turn, to reconnect with Maria? What does she need to say?
I think she needs to be reflective of the statement that she said, that she does not want it to be like this. So she can build off and work off of that statement, but not where she went with the cape, Yeah. Mm-hmm. She just shut her down at that point.
She did. Other folks, what would you say? What would you say, or what do you think the next step for Gabriella should be?
I think to actually own her feelings, to help her to repeat back, reflective listening will repeat back her statement about you don't want it to be like this, these feelings that you're experiencing, and talk about her feelings at that point so that she can reflect on what she just said, and that you let her know that I hear you,
Mm-hmm. And I think maybe what Gabriella needs to do is, the things we learned yesterday, right? So maybe Gabriella needs to uncross her legs, lean forward, put her hands on her knees, push her heels and toes into the floor, and say, wow, that came out wrong. That came out wrong. And I'm really sorry that's happening to you. So I think, you know, recognizing that Gabrielle is a person with feelings and we all get triggered, we all jump the gun, we all jump to doing or putting on our capes, you know, and it's something that we can recover from and we can repair the relationship from when we can become more present and notice that that happened, notice where we are, and then repair the relationship through that. Other thoughts on this scenario? Other ways you would repair the relationship? Or do you have an example of when you had to repair a relationship with someone in the clinic or someone you were doing case management or home visitation with? Anybody want to share? Okay. So really, again, noticing where you are, paying attention to the body language of the person in front of you, noticing that feelings is a place that we tend to shy away from, and trying to be present and with that person in order to support them to take those next steps, I think is really key. So what do we know about the FAN from home visitors and supervisors? I think it allows you to stay in process longer and not rush to fix it when you're able to be present with yourself and really noticing, are you in the same place with the client or are you trying to jump to somewhere else? It helps you stay calm and regulated in difficult situations. I think you can see things more from the parent's perspective when you do that, or from the client's or mom's or birthing person's perspective. You can be more comfortable with holding and exploring complicated negative feelings. You elicit more information, you get more when you can sit in those kinds of places. So I know that I said, you know, disclosure isn't the goal of what we're doing with universal education, but we know when we open doors for people to chat, like over that tuna salad with the caper juice in it that I talked about in the backyard with Kelsey, that we're able to, that people are going to say, hey, this is happening to me, I need some help. So I wanted you to have tools to support you if there is a disclosure. I think so disclosure is not the goal and disclosures happen. You know, what the research tells us is that clients want us to be non-judgmental. They want us to listen. They want us to offer information and support and don't push for disclosure. So I think one of the things that clients really want from us is empathy as opposed to sympathy. So I'm going to share this video about the difference between the two. It's by a researcher that I talked about yesterday. Her name is Brene Brown, and I think she sums it up nicely, but I think that's a great example of what survivors need and want from you.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." I had it, yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, "I don't even know what to say right now. I'm just so glad you told me." Because the truth is, rarely can a response make something better. What makes something better is connection.
So I don't know if you'd seen that video before, but I love the way it ends, right? I don't even know what to say right now. I'm just so glad you told me. We're not looking for you to be experts in domestic violence and intimate partner violence. What we're looking for you to do is have some words of comfort. And I'm giving you a list right here, right now, so you can take a look at this grid. These are things to say for people who have experienced power and control, abuse, trauma. I believe you. I'm so sorry this is happening to you. Thank you for sharing this. I don't even know what to say right now. I'm so glad you told me. Yes, we took that directly from Brene Brown. You don't deserve this. Thank you for telling me. It's not your fault. You're not alone. So I want you to know that the DV hotline is also there for you as well as the client. If you have a situation where, my doula friend who shared out before, it's like, I just had somebody yesterday who's, out of this relationship right now. And, maybe you want other ideas about what could help, so you can call the DV hotline and say, hey, this is the story with my client. What other ideas should I have, or do you have for me about how I can help this person? Also, your phone is your friend. So for somebody who's in an abusive relationship, and if you're doing a virtual visit, know that you can tie in a third call. I mean, if your phone allows for it, you can call the DV hotline if the client wants that. And you can do a 3-way call, but it won't show up on the client's phone. And that's a way to improve their safety or engage in harm reduction. So know that you can do that as a safety measure. Also, if you're in a clinical setting, please do offer your clinical phone or your personal cell phone, because what do we know about abusive partners from that earlier video today? They have your passwords for your texts and are looking at your call log, right? So the importance of offering another place to connect with resources is incredibly important. So I want to just remind you all of that. And we really want to, again, let the survivor drive. They've been surviving the situation for months, years, weeks. And we want to, provide them with help and support in the way that they want it. So we want to keep the relationship in mind. We want to check in with her about her partner's potential reaction. I mean, I'm not saying we don't want to understand, like, you want to ask a question if someone said, yeah, things are really hard. You definitely want to ask a follow-up question where you say, so is there ever a situation where you're like afraid for your physical safety or the kids' safety? Tell me, is that part of this story? And you might find out that it's all about just financial abuse, or it's about emotional abuse, et cetera. But you definitely want to understand where things are and understand what the client is doing to keep themselves safer. You want to listen and problem solve with her or them. about what they might need. And, you know, again, survivors have been surviving for thousands of years. So we want to know, what has she or they done in the past that helps? Who or what is supportive in their lives? So I think these are all just key considerations for you all. It's okay to say, I don't know. Again, use your hotline friends, and feel comfortable saying what you do and don't know. Clients respect that. I'm not an expert in this, but I know where to go to get help and information. Would it help if I made a 3-way call? If I call the advocate first, I can add you to the call and no one can trace who you were talking to from your phone. So again, maternal health providers do not need to be DV experts to help clients experiencing domestic violence. I do, however, think that one of the things I would like to see changed in my lifetime is that every maternal health care provider has a memorandum of understanding with your local domestic violence agency, has a partnership there so that you can really rely on their expertise. As a clinic director doing perinatal health care, I definitely had experiences where somebody had disclosed and they were scared to death and they wanted help right then. And I could call my local shelter because I had a relationship with them. Their name was Safe Haven. So I was doing, we were sending nurses over to do reproductive health care to the folks in shelter and offer, you know, birth control and all those kinds of things, do health education there. And then when we had what we called a hot positive, where someone is, you know, needing help right now, if they had the ability, they would send somebody over to the clinic and take over for us. So we would say, you know, you can do whatever it is you need to do around safer planning, or, you know, what the next steps are, or if she wants a restraining order, or all those things. And then suddenly the weight was off the clinic. And that partnership made a huge difference. And I can tell you, as someone who did it, it was the biggest blessing ever, because we had, it freed up so much time that people would have been running around, you know, not knowing quite what to do. And it freed up time, and it met the needs of the client better. So safer planning is a process, right? It's a conversation. It's not a form. So has anything changed since we last spoke? How are things going? What can I help you with? How are the kids doing? Even without a crisis, I know it can feel like a lot of responsibility, but I do think that the survivor is going to be key in terms of you understanding how you can help best. So survivors tell us the time she took just listening to me mattered more than she knew. Please hear that, right? The time she took listening to me mattered more than she knew. No one just listens, which goes back to being able to sit with feelings and listen. So ongoing safer planning reduces isolation, and it allows us to explore options for safety and autonomy. So as my friends at Whiskative say, and this is their little infographic, connection is the antidote to isolation. And you, all of you on this call, are part of that connection. So I want to share, you know, Washington State has done a lot with home visitation and maternal care. And so I want to share with you some of the things that their home visitors shared around intimate partner violence and when they received training on the subject.
I always thought the experience of intimate partner violence was cut and dry. I always thought that experience and the solutions were straightforward. And now I understand the complexity and the multifacetedness of the experiences of the families that we serve, and that it's not always going to be cut and dry, and that the way forward will not always be clear in the beginning, that it will be something that we will understand together over time.
I always thought that survivors needed to leave in order to seek services, but now I know that it's not always the solution.
I always thought that people who are domestic violent were victims. Now I know they are not victims. Instead, they are survivors.
I always thought that as a home visitor, it was my job to have all of the answers. But now I know that the families and the people who are in the midst of the situation actually have the answers that they need that best suit themselves, their situations, and their lives.
I always thought that we should always think about others first. But now I think that question or putting ourselves first is in the relationship is what is most important.
I always thought that the goal was for the person who was being abused to leave the home, but now I know that's not the case.
Okay, I always thought that if you do not disclose that you are experiencing DV, nobody will notice. And now I know that even if you don't say anything, there is a little signs that everyone can see. And it happens to me now that it's like you develop a sense that this person is experiencing or her relationship is not as good as it should be.
So I love that she has that little intuitive, that little, you see that hesitation, as you can imagine when you.
I always thought.
So I also want to just give a moment, because I realize that some of you are working with whole families, not just with moms and birthing people. And so I want to talk about leveraging moments with the person causing harm for those working in those settings, right? So should you have a conversation with them? One of the things that I hear from home visitors, case managers all the time is like, okay, they broke up, but now they're back together and he's in the house. And what do I say? Because of course I know why they broke up and why they got, all the things, right? And so one of the things that we're seeing happen and be successful in the field is, if you have a relationship with a partner who's used harm, there is a way to sort of support them in change, right? So we want to establish, build, and maintain rapport, identify supports, listen for shared goals with the person who causes harm, and we want to practice it. And I'm not saying this is something you should willy-nilly do when you go into your next home visit, but I do want to say that there are resources and tools that can help. And for anyone who's working in a fatherhood-focused program, I really think that there's a lot here for you in the work that you're doing. And I think Bell Hooks says it best. She's a brilliant thinker. And how do we hold people accountable for wrongdoing while at the same time remain in touch with their humanity enough to believe in their capacity to be transformed? And so going back to our hope discussion earlier today, if we frame things in the positive and the hopeful and the things can change way, we can do a lot for families. We can do a lot for folks who have caused harm in their families. This is a great tool. And Kelsey, if you're on, maybe I'll just go ahead and, well, it's on your list, so don't worry about it. But this is a brand new hot off the press tool from Futures Without Violence, for fathers or others who have engaged in harm. How do you want your kids to remember you? And while this is targeted at fathers, I think actually there's application to use with whole families for sure. And I'll share a little bit more about what's happening in here. Right, so it goes into detail about what happens for kids when they're in homes divided by age, where there's intimate partner violence. How does that show up in kids? Fussiness and crying a lot, frequent sicknesses, difficulty sleeping for infants, toddlers and school-age kids, withdrawn and sad, aggressive to others. So we see a range of behaviors, delayed development, stomach aches, not being able to potty train, or reverting back if they've already been potty trained, wetting their pants, or having difficulty sort of paying attention. poor motor skills, and then school age kids. So we see all the, we get to learn about how violence impacts kids. And then we also get to learn about what helps parents, what helps people. And what helps people is power, right? So we want to notice in a situation in a home where things are going wrong. We want to pause and keep the situation from escalating. We want to organize our thoughts and feelings. You remember back to that panel of the card called Strong Families. It's basically laying this out, right? You want to notice that you're upset. You want to take a breath. You want to go outside, wash your hands, etc. So that you can come back and be in a better place. Where are those feelings coming from? We want to entertain the repercussions. What's going to happen if I don't stop myself? And then we want to respond according to our values. And I think when we break things down to values, it really, again, allows us to have very different conversations with families. So you can see here, these are all tools from inside this, how do you want your kids to remember you toolkit. But what did, pause. What did you say to your partner or ex-partner before, sorry, it just popped over my screen. Before taking the pause, did you tell them when you would be back? If not, can you text them? I mean, so it's really walking you through, like, when you're in a hard place, it's helpful to have steps to take to regain control over your emotions. Organize your thoughts and feelings and be aware of your physical reactions. Are you hungry? Are you tired? Are you angry about something else? When you started to get angry, how did your body react? Are you getting tense? Are you pacing back and forth? Are you sweating? Again, we learned this yesterday about, like, where am I when I'm in a good place? Where am I when I'm in a bad place? You can see here why teaching parents or clients or, moms, birthing people, that piece of information, noticing where they are, that can make a big difference for all kinds of things in their lives, including parenting, right? So if you notice that baby's crying is making you have a really hard moment, noticing that before you do anything to try to make the baby be quiet, obviously is a great step around child abuse prevention. So that whole thing about noticing where you are, and if you're upset, what are you going to do to change it? Huge implications for everyone. But I think this is a great resource for anybody who's working with folks who caused harm in the past or currently doing it. So, here are some steps. Again, these are from my friends at WSCDIV, the Washington State Coalition. We want to go slowly and attempt this when you've had a history of conversations and you have a established relationship with a person that caused harm. You want to pick a question and practice. You want to pick a part of this toolkit. You want to debrief it with coworkers, reevaluate it, try it again. Observe the person causing harm and listen for their capacity to explore their relationship, tolerating differences and their understanding of parenthood. Look for ways to build on beliefs or actions that will help them be a better parent. What are they doing now that they're good at? How do we do more of that? Maintaining a routine with kids is really important. Reading to them instead of controlling the other adult, what the other adult is doing. I mean, just again, but we start with what are the things somebody's doing well, and then you use that as the starting point, right? But then moving on to the things maybe somebody wants to change or behaviors that have been hard. And I know this again isn't for everyone on this, but I wanted to take a moment just to make sure we didn't leave anybody behind if this is what they're working on. So I'm going to recap our journey because we've been on a journey to get today together. We started out yesterday with noticing yourself. Where are you? How are you? So mindful self-regulation. You learned yesterday about the fan and a way to stay attuned to your families. We talked briefly about the ARC. So for supervisor friends who are interested in integrating reflective practice into their programming, that was covered yesterday. If you missed the talk yesterday, it is recorded, so you can learn about it. You can learn about it later. Today we learned about ACEs and the HOPE framework and really building on the positive with families. And again, I'm going to go back to how many tools measure the hard things versus how many tools are measuring the good things, or how many of our conversations start with the strength-based approach. We talked today about IPV and the experiences of Black and Brown families, systemic racism, implicit bias, overrepresentation in the child welfare system, how that doesn't help kids in a lot of cases. We talked about the limitations of disclosure-driven practice, so only using screening tools. I think we kind of know too much to keep doing that. I think we need to integrate cues and universal education, because we know that there's such a small percentage of disclosure in your practice, yet there's a huge amount of intimate partner violence that's happening in the world. The power of letting people know where they can get help. And then we learned a little bit about safer planning as well. So just a reminder, I gave you like a snippet of the fan, just a snippet. There's more where that came from. I think it's a beautiful model. If you're interested in more training for you or your staff, you can contact Linda Glickerson at the Erickson Institute. Somebody asked, how do I get safety cards? How can I order this? What's going on? So you can email us at health@futureswithoutviolence.org. You can go to our website. We have a really robust website for providers called ipvhealthpartners.org. So we can, again, if you're interested in more on the MOU, interested in more on other videos that can help you in your practice, if you're interested in sample protocols, other kinds of things for your setting, it's all right there. So know that that's a resource for you. Futures has many, many different arms. One of our arms is really focused on children. If you're interested in more on how to help children exposed to violence, Promising Futures and Promoting Resiliency is a wonderful tool website, and you can see part of what's cool about it is it's looking at what is needed for you and the person that you're helping. So are we looking for individual supports? Are we looking for family supports? Are we looking for community responses and supports? It kind of covers all those things. There's a whole bunch of tools there to use with kids and families. This is one of those tools. I love this because it's also something you can order. It's in English and in Spanish. And what it's doing is it's looking at, it's looking at 8 ways parents and caregivers can help kids who experience trauma. It's specific action steps, and kind of you can see it's like kind of a cartoon format that folks really like, and they're concrete things that you can do every day with your kid, whether they've had trauma or not. I mean, everybody benefits. Kids benefit from supports from parents generally. So I'm just going to share a little bit more of the research here. And I had the opportunity to do the qualitative research on cues back in the day. And so this is a client that will forever stay with me. And here's what she said. So there'll be times where I just read the card and remind myself not to go back. I'll use it so I don't step back. I'll pick up on the subtle stuff because they'll trigger me. I remember what it was like. I remember feeling like this. I remember going through this. And I'm not going to do it again. For me, it just helped me stay away from what I got out of. I carry it with me, actually. I carry it in my wallet. It's with me every day. So we know that the cards also are like talisman, are these things that people kind of keep in their wallet or in the top drawer next to their favorite earrings or wherever. People keep them in the glove compartment. We got to ask people, where do you put your cards? Do you keep them? Did you give them away? And we also know that people want to help other people. So we definitely saw folks coming into the clinic, and this is when I was a Planned Parenthood clinic director, coming into clinic saying, my friend gave me this card and I wanted to talk to somebody about it. So it's a pretty cool intervention. I want to thank you for your time today. And I want to say it's so important to do an evaluation because, as I mentioned, you are one of the first audiences in the country to see this. We are still in tweaking mode. So I know that Kelsey's going to drop this evaluation in the chat. So I want to acknowledge that. And I know that there are some of you who are interested in being trainers. And so I'm going to open this up to a Q&A here for a little bit. And then if you're interested in talking more about becoming a trainer and doing the training of trainer series with me, there'll be time to do a little Q&A on that as well at the end, but we'll save that conversation for later and focus on the content for the Q&A now. Okay, so I'm going to ask you to use the chat one more time. I would love to hear from you. What is a word that captures what was meaningful for you in the training today? So what was meaningful for you? I'd love to hear. Insightful. Empathy, sharing feelings, informative, reflective, strategic, thought-provoking. Thank you for that. Informative, compassion. Well, I just really want to thank you, and I'm hoping I can convince all of you. We stopped a little bit early so we can convince you to fill out that evaluation. I want to hear what can be better. I would love to hear what really worked for you. And I'm just deeply grateful for each of you.